live stream coming up in a couple of honored on your call. E na hoa makamaka mai, Hawai'i nui o ke awia hiki ni I hau ka helelani na kamaaina na malihini aloha. And for those of you that do not understand Olelo Hawaii, hi. Thank you very much for being here, for not only those that are here in-house today, but also for those of you that are watching online. Welcome to the 2022 Hawaii Parkinson Association Symposium, and we are really glad that you are here with us today. We have lots for you, short preview here. We've got interviews, we've got lots of people and agencies that would like to help you or give you information that would be helpful. We've also got several skits that are, for lack of a better term, chicken skin. So we are looking forward to this and much, much more coming up on today's program. Ladies and gentlemen, please welcome the president of the Hawaii Parkinson Association. Please welcome Jerry Boster.
Thanks very much. Let me try that again. Thanks very much, Billy. I'm really excited to be here. Let's see if I can find my notes. There we are. So, aloha kako. Welcome back to the Hawaii Parkinson Association Symposium. It's so good to see old friends and meet many new friends. I've talked to so many of you over the last 2 years on Zoom, but I haven't met very many of you. And so this is the first major event we've actually tried in over 2.5 years. And so I really appreciate everybody coming back, coming out in this terrible weather. It's so terrible we had to put up tents just to make sure that you didn't enjoy it. Try this again, I'm not close enough. And one thing I've learned as president is that everybody's busy. And so for you to come out and share some of your valuable time with us is really exciting. We had 105 people registered to be here in person. As of last night, we had 66 people online registered, including as far away as Mr. Michael Fitz that I work with Michael J. Fox Foundation in Alabama, to former board secretary Lindsay Sutton in Texas. We've got some friends up in Colorado from the Davis Finney Foundation. We've got folks from all over the place tuning in just to see this event and us going after what I consider a very hard topic. This topic isn't a popular topic. Popular topics are exercise and diet, nutrition. They're what I consider the easy ones. Mental health is a hard one. I call it one of the dirty little secrets of Parkinson's, when almost half the people during their journey will have a significant mental health challenge. It's something that we haven't really dealt with a lot, but we needed to. And so after a couple of my close friends who have Parkinson's told me of their struggles, it caused me to reflect on my own journey so far in the 8.5 years I've had Parkinson's. And I realized that I've had maybe not clinically diagnosed cases of depression, but I've had too many cases. One was when I got my initial diagnosis. It's not a surprise, just the bewildering situation that it is and the unknown and just the whole situation. I was very fortunate at the time. The gentleman that really helped me see it through was Dr. Webb Ross, because I was in a clinical trial, so I was seeing him really frequently, along with his partner next to him, Helen Petrovich, both doctors. They helped me out a lot on the professional side. And then all my friends I tailgate with, and then of course my wife, they got me through that. And then fast forward to the pandemic. I'm a guy that works 40 hours a week in a day job, do another 20, 25 hours a week doing this job. So I do quite a few hours. Then all of a sudden I'm sitting at home. I'm going to work one day a week for half a day. The rest of the time I have a sofa, nice recliner that has my butt cheeks on it from watching so many hours of Disney and Amazon streaming. And it weirdly weighed down on my mind. And it wasn't until we kind of worked through it and started to get back to normal that I looked back on it and saw it for what it was. And so these situations, when I combine them with what my friends had gone through, told me if somebody like me, who I consider myself a pretty strong individual, is having this problem, then there's a lot of other people that are too. And it's not acknowledged, but we need to get after it. So today, I decided to think out of the box, and this is the result of a few months' work with a couple of my partners, Kai and Glenn. We had a lot of input, and what you're going to see today is two skits. One is based on a young onset scenario, the other is an more advanced scenario. So kind of from two perspectives. I have to give a big shout out right up front to the University of Hawaii School of Nursing and their medical emulators. They're fantastic actors, and you're going to get to see them here in a few minutes. You're not only going to get to see them, you're going to get to experience it. I watched the rehearsal yesterday, and as Billy said, chicken skin. And it also gave me a couple flashbacks to some of my early diagnosis. But I did this so that you can see it, you can feel it, but then we're going to bring up a panel of doctors, and we're going to try to give you the tools to help yourself, to help others work through these types of things. But the thing to remember is, I'll say this, most of you are not doctors, so don't try to do it all yourself. Always remember there is help out there for the patient and for yourself, because caregivers, we love you too, and you need to love yourself and get help as well. So with that, that's kind of a preview of what we're going to do today. Got to put a plug in for the Resource Center. Pat Bemis, Resource Center lead, right there. If you haven't been to our Resource Center, please, 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 before you leave today, go visit. It's a really nice place. We spent a lot of time and effort to make it a warm, welcoming place. People can come there, get information, connect with other Parkinson patients, connect with caregivers. So there's all sorts of people that you can connect with to get help. And that's what we're after, is to give you information, give you the help so that you can make informed decisions about what needs to be done for your best course of action to make the best quality of life that you can have. With that, let me introduce some of my Hawaii Parkinson Association board members. Please join me on the stage when your name is called. Start out with Executive Board Member, Treasurer Randy Tsushima. Randy, where are you at? Here somewhere. One that I already mentioned, Pat Bemis. Please join us up here. Board Member Amber Curtis. And most recently, our brand new board member as of last Tuesday, Julian McAleer from Maui. And I want to mention the folks that weren't able to be with us in person today, but most of them are online. Tom St. John from Kona, Fran Calvert from Hilo, Aaron Davis from Maui as well, Lisa Kubota Moffett, and Linda Conboy. I also want to thank all the volunteers. If you haven't noticed, I think we have about as many volunteers as we actually have participants. And that's a tribute to all the people that do want to do good work and help us out. Lastly, I have to thank our money people. I need to thank our sponsors and vendors, led by the gold sponsors, St. Francis Healthcare System of Hawaii, represented by Jerry Correa, the CEO, who you'll hear from in a minute. Hawaii Pacific Neuroscience Parkinson Research Unit, represented by Jesslyn Lee, and the Queens Parkinson Movement Disorder Center, represented by Center Director Dr. Michiko Bruno, who you'll be hearing as part of our panel. We definitely appreciate your continued support. Without you guys, we couldn't make these events possible. Now it's time for me to do what's hard and shut up, because everybody knows I like to chat a little bit. And I need to pass the microphone to a good friend and a person I consider my healthcare business mentor, and just all-around good guy, St. Francis CEO, Jerry Correa. Jerry?
Thank you, Jerry. Today's really a special day for me. Where you're sitting here today is the center of our Kupuna Village, the courtyard. And 10 years ago, the vision of the Kupuna Village, besides having multiple geriatric services for the seniors and the caregivers, we developed this courtyard as a place, as a gathering place, to be a place where people could get together and learn. There's a lot of education going on in this courtyard. We've got caregiver education, exercise classes, a cooking demonstration room, and so forth. That was the vision of this courtyard in the middle of our Kupuna Village. So today is the first time that we're having a larger event since COVID. So I'm very excited because this is the intent. So 10 years ago, as we were coming up with the vision of the campus and again, trying to get services for our seniors, we started interviewing seniors and telling our kupuna we're about to build a campus with assisted living, memory care, skilled nursing, geriatric services. And as we gathered the seniors together and voiced our vision for the future, we noticed that the 80 seniors that came on campus to hear this brought their adult caregiver kids with them. And as we spoke and asked questions, what do you think? The caregivers were answering. And so we started to discover that as the seniors are getting older and the population's getting larger for a Kupuna population, so is the caregiver population. So what can we do for the caregivers? So we started brainstorming and coming up with different plans for this. And we noticed that there are areas in caregiver support, especially support groups, like the Parkinson's Association, that there's a need for getting together and learning and getting educated. And so that is the first time I came across Jerry. And I gotta tell you, his passion for what he does is inspiring to me. And I will do anything and everything. And I got to watch out when I say that, because he always goes, well, reduce the rent then, you know. But I will do a lot for this guy because he has so much passion. And I think it's very special. And again, today is just a special day. This is the first time I'm seeing this. That, you know, when you working on a vision for 10 years and you see it coming to fruition, it's inspiring, and I'm so grateful for that. But there's a lot of learning going on, and I'm very appreciative, and I just want to welcome everybody today here. We have a great partnership with the Parkinson's Association, and like other things that happen in Hawaii, partnerships, relationships, we do things for one another, and I'm very honored to be considered a partner here at St. Francis with the Parkinson's Association, because in Hawaii, everything is about relationships, and everything's about taking care of one another. So I welcome you here today. Very excited. Great time. Learn, enjoy, and have fun, everybody. Thank you.
One of the things that Jerry mentioned was this is a learning experience for all of us. First time we've done this here. In your bags, there's an evaluation form. I'll mention it now, we'll mention it at the end, but we would appreciate greatly if you would take and give us honest feedback, what we did right, what we did wrong, and so that we can make this event better. We'll pass on the results to St. Francis as well, because they are very much a partner in this, and so much of what we did out here was because of them and their willingness to work with us. So please just let us know how we did, and then you can put it at the registration tables on your way out. Be much appreciated. So now we're going to go on to kind of the main events. The first one, and I called them, when I put out the flyer, I called them an interactive session. And it's interactive because we do want feedback and interaction with the audience. So here's kind of what's going to happen. We have the medical emulators, the actors, who are going to perform a short play of roughly 10 to 12 minutes in length. In this play, one of the actors portrays a person with Parkinson's, and the other is a caregiver or care partner. Their performances are going to highlight one or two of the Parkinson's mental health challenges. Once the scene is over, the actors are briefly going to relate some information about their characters they portrayed, just to help everybody make sure you understand what we were kind of getting at, because we don't have a lot of time to develop. So we want to be very direct on this. While this is going on, we'll ask our panel of doctors who are subject matter experts on Parkinson's to come up on the stage. I'll ask the doctors a couple questions to kind of kick off the Q&A area. And then I'm going to open up the Q&A session to the audience. We'll have some of the pre-medical association students. We'll have cordless mics. All you have to do is raise your hand, and they will come find you to ask, so you can ask your question. The goal of the Q&A is to have a good discussion on mental health challenges that you saw in the skits, and then provide you with some ways to deal with the challenges. One note, as we've worked through the skits, these are tough situations, and as befitting any tough situation, they can sometimes get into dark aspects. We recognize that, and we don't want anybody to go home in a bad mental state. So we've tried to craft them to stimulate discussion, but not kill you at the same time. Bad way to put it, but I think everybody kind of understands what we're after. We really want to have the useful discussion, because that's really what this is all about, because that's how we learn, is through discussion. So with that, does everybody kind of understand what I'm after? Anybody really have any questions? Lots of heads going up and down. So what we're going to do is we're going to set the scene. So I'm going to turn it over to Billy V to start off the first scenario.
Nice round of applause for Jerry, everybody. Thank you, sir. I'm going to go over on this side and go over here. And we'll wait for audio. No, we won't. By the way, sound, we're going to do an audio test here coming up in just a couple of moments. And, oh, yeah, you're more than welcome to, if you want to come up and be front and center, you're more than welcome to move up. Thank you so much. So, let us begin. Welcome to the Hawaii Parkinson Association Theater. As Jerry discussed, we have two scenarios today. The first scenario is an Air Force jet going through the sky loudly. But that shall soon pass. And hopefully that's the last one for the little bit. Okay. The first scenario is based on a young onset Parkinson's disease situation, YOPD. It's written and directed by Alex Munro. Maria is performed by Christine Chang. John is performed by Robert Torigoe. Nice round of applause for them, please. Just to make sure for sound, since this is the first skit, I'm going to ask each actor to count to 15 for me, and just to make sure that the audio levels are set and that we're all good. Sir, if you could, please.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Sound, if we're good, give me a thumbs up. One more time, please.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Maybe 20 is a better number. Christine.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Thumbs up from sound and video. Thank you very much. For those of you that are watching online, I wanted to make sure you could hear. Okay, here's some background to set the scene. Maria and John are an average couple. They've been married a little over 10 years. They have 2 children. Nate, age 9. Kara is age 7. First of all, Maria works full-time in construction, aspires to be a crane operator because of the prestige, working conditions, and high pay. Active, athletic, she does yoga 3 times a week, doesn't smoke, drinks alcohol at social levels, eats fairly healthy meals. That's Maria. Let's talk about John for a couple of moments. Male, late early 40s. We'll say mid. Works as a mid-level IT professional at a prominent local insurance company. Active, athletic, jogs 2 to 3 times a week, plays softball, doesn't smoke, drinks alcohol at social levels, eats fairly healthy meals. Maria recently received young onset Parkinson's disease YOPD diagnosis. Watch.
My husband never cooks. It's been our arrangement for the past, 13 years now? I do all the cooking and repairs around the house, and he takes care of anything that has to do with computers. It was our deal, and it worked. It's only been 48 hours since the diagnosis, and already everything is changing. Now I'm the one on the computer all the time. I can't stop reading articles and watching videos on advanced Parkinson's, and even though I have years until I get to that point, I took my son Nate to the mall 3 years ago for Black Friday. He slipped out of my hand, and in an instant, he was gone. I like to think of myself as a pretty fearless person, you know? But in that moment, I had never been so afraid in my life. Time somehow moved too fast and too slow. When I called out his name, my voice came out weak and shaky. I pushed through the people with their shopping bags and felt angry that they just kept staring at their phones, oblivious to the crisis unfolding around them. My son was lost. He could be hurt or taken. How could they not see? How could they not see what was wrong? Why weren't they as scared as I was? I found Nate eyeing some cookies next to one of those kiosks where the employees try to rope you in with free samples. Just as I had never been so scared in life, seeing him filled me with an intense relief that I had never experienced before. 2 extremes in one day, just minutes apart. Abject fear, total relief. When I read those articles and watch those videos, when I see what awaits me with this disease, I'm back at the mall. Abject fear, alone in a sea of people, oblivious to the crisis unfolding. But unlike the mall, it's been 48 hours since the fear began, and I haven't experienced anything close to relief.
All done?
Huh? Oh,
You feeling
Yeah.
okay?
sorry. Not hungry, I guess.
Okay. Want me to put it in the fridge for later?
No need.
Okay. You know, you can take a break.
And do what?
I don't know, whatever you'd like.
Well, what I'd like to do right now is read this article.
What's this one about?
How this is going to affect our sex life.
Don't let me stop you then.
I still want you to want me even
Of
after.
course I'm going to want you. That's not going to change.
Yeah, you say that now.
Have you thought about how you want to tell the kids?
Not really. I mean, I know we should tell them sometime soon, but and I know how this sounds, but I just don't want them to see me differently. as someone who's sick.
Well, you've been sick before, and they still called you Mom, so I think they can handle it.
This is different, though. I'm not going to get better. I also don't know how I'm going to tell Chuck.
Do you have to tell him right now?
Right now, probably not. But what happens when things get worse? How am I going to keep working if I can't trust myself to hold a hammer, much less run a crane?
Then we find you another job where you don't have to do that kind of work.
Doing what? I don't have any other skills, John.
You could go into project management, or you could become a consultant.
Oh, right, because folks are going to want to listen to some chick who can't stop drooling or shaking.
Do you really think people are that cruel?
I just don't want them to feel sorry for me.
Well,
I don't need their pity.
don't ask them to. Babe, you're the same person I fell in love with 15 years ago. That's not going to change. Yeah, it's going to be difficult. We're going to have to navigate through some changes, but in the end, it's still you.
I'm scared.
I know.
I hate that I don't know how long I have until things get worse. How long until I can barely walk or need you to feed me because I can't hold a spoon straight.
Don't think about that.
That's all I can think about. It's the not knowing that's killing me.
Well, why dwell on things that are beyond our control? We could focus on things we can do now. We can tell the kids. We could make a plan to transition you out of construction into something else. We could get you furniture so we can make the house safer for you.
I don't need you child-proofing the house, John. I'm not a kid.
I didn't say that. I'm just trying to help.
You're treating me like I'm something fragile.
Yeah, because right now you are. I mean, it's okay to be.
I can't do this right now.
Oh, shit. I met Maria in high school, and she was mean. There's no other way to put it. She was in this clique where they all thought they were so hot, and they wouldn't talk to anyone who wasn't cool or popular, which I wasn't. So, even though we had a few classes together, we never spoke. Didn't really matter to me, because all I could think about was getting the hell out of high school and going to a college in the mainland. So I went to Michigan State and I studied computer science. During my junior year, I came home for winter break and I ran into Maria at a holiday party. To my surprise, after a few drinks, I found myself talking story with her in the kitchen. I don't know if it was the drinks or what, but she seemed different. She seemed humbled. And all that self-assurance that got her through school, well, it was like she refocused it on caring for her mom and dad and her aunts and uncles who lived with her. So I asked her out. And that was definitely the alcohol, because I was kind of seeing someone at MSU. But she said yes. It's funny. I had this grand plan for my life. Get good grades in high school, go to college, get a high-powered job in the West Coast. Getting married and having kids was incidental, a nice thing if it could happen, but not something I could plan. But now I can't imagine. I don't want to imagine. what life would be like if I hadn't asked her out. I wouldn't be Nate and Kara's dad. I wouldn't be Maria's husband. And don't get me wrong, I'm not just a dad and a husband, but I never thought that being a dad and a husband would be so important to me. But this was not in the plan. And Maria, she's sick and she's not going to get better. And I have to be more than just a husband. I have to be a care partner. And a dad to Nate and Kara, and a working professional, and I don't know where to start. Oh, Maria, she has done enough reading for the both of us. And I look at those videos because I'm trying to, get an idea of what's going to happen to her, what's going to happen to us. And I start crying, and I hate myself for crying because that's the last thing she needs right now.
Sorry.
It's okay.
No, it's not okay. You're incredible. And I don't know how I'm going to get through this without you.
Look, I'm not going to pretend it's going to be easy or that I'm not going to make mistakes, but, it's going to get easier. We just got to learn how to talk about it. And I'm going to be right here for you every day. You're stuck with me, Mrs. Ferris.
I love you.
I love you more.
Don't you dare, Mr. Ferris. I said it first.
Well, I asked you out first.
True. Even though I was mean.
Well...
I was confident.
Oh, is that the word we're using now, today?
Well, look at me now.
Yes. Look at us now.
Scene. Nice round of applause, ladies and gentlemen. I'm going to ask John and Maria to kind of stay here for a couple of moments. I know they're moving things off to the side. Appreciate that. Look at that. They cleaned the table too, yeah? They not only act, but they clean house.
Yeah.
John and Maria, introduce yourselves real quickly to the crowd.
Yeah, hi. Sorry, go, Christy.
Hi, everyone. I'm Christine Chang. I played Maria.
I'm Robert Torigoe. I play John.
Great skit today. Share us with the audience some insights on your character.
Yeah. He's struggling. He's fearful. He's scared of the unknown. And I think he also doesn't really want to accept what the reality is going to be. Deeply in love with Maria and the lives that they have. Yeah, I think he wants to do the best he can, but he also knows, I think he knows there's some limits that he has in himself that he's struggling with.
Yeah, and I think Maria is in shock for most of it. I was lucky enough to be able to meet with Kai McDermott, who she answered all my questions about how she personally was feeling and what she was going through, and that helped a lot. And it was a lot of what was already written in the script, which was just fear, shock, not knowing what to expect, going down that research rabbit hole. So just playing a lot into of the unknown and thinking about worst case scenario.
more time, ladies and gentlemen, a nice round of applause for our...
Great job. Wonderful job. Thank you.
Would you like to move the table?
And sound, I have microphone number 4 in my hand. Thank you. Test 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. What we'd like to do now is we'd like to bring up to the stage. Please welcome Dr. Michiko Bruno, Jim Spira, and Pat Borman. A nice round of applause, please. And with that, I'm going to bring back onto the stage at the podium, Jerry Boster.
Thanks, Billy. Let me talk to Dr. for just a quick second.
Sound, I'm turning on microphone number 5 for our panel here. Test 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Test 1, 2, 3, 4, 5.
Okay, like I talked about before the skit, I'm going to go ahead and start off with a couple of questions for the docs, just to kind of set some basic knowledge, make sure we're all on the same page. First question is, how common is depression and anxiety? And I'll kick this one to my movement disorder specialist, Dr. Bruno.
Thank you so much for that amazing skit. The script is well written. It's just really, I think it went deep into all of us. I think it touched all of us, and the acting was just really moving, amazing. So with that, I think the depression and anxiety is really common in Parkinson's. It's almost inseparable. Statistics shows that up to 40–50% people with Parkinson's will at some point have anxiety and depression, as well as caregivers. So I think it's a very common situation, and it's not a sign of a weakness or anything like that. It's just inherited. Life is challenging as we know it, and I think it is part of it, as well as biochemical changes that happens in brain. So I just kind of want to emphasize that this is an extremely, extremely common situation that we can all relate to.
Thank you, Doctor. Now I'm going to go to the other end of the stage. When I was talking in my remarks earlier, I mentioned clinical definition of depression, that I may have not met that. Dr. Spira, if you can you tell us what the difference between depression and anxiety are, kind of the definitions of them, so people understand kind of what we're actually up against? I'll just leave it at that before I get myself in trouble with.
Sure. No, excellent question. And let me start by saying the skit was a wonderful introduction to this, because you could see that in this kind of early onset, it was really preliminary to advanced brain changes, but you could see her distress and the distress of the spouse as well. And this is natural. I'd call this more of an existential angst. The shift, the unknown, the shock of the diagnosis, the fears of what's going to happen, naturally would have anybody distressed at that thought. And that's a healthy, natural state to be in, because it shakes one up, it makes one start to take it seriously, starts to readjust how they're going to be in their life. So this type of distress, I wouldn't call so much a clinical depression or anxiety, I'd call it a healthy adjustment. But if you see people start to, for whatever reason, even before the organicity of the disease starts to affect the brain and cause mood changes, even just for what we saw in the skit, if someone starts thinking about it so much that they can't think about anything else, if their thoughts are always worried about what's going to happen, then that can cause dysfunction in their life. They're not able to adjust and adapt and move forward as well as possible. So that could lead into what we'd call an anxiety or a depression disorder that could be the focus of either psychological psychotherapy treatment or medical medication treatment. And some of the symptoms to look for, besides kind of an obsessive worry, could be physical symptoms, feeling panicky, heart racing, the breath going shallow and rapid in the chest, feeling sweaty, kind of a little panic, sometimes going to a full-blown panic from time to time. Mentally, people's thoughts are racing so much that they can't really focus or concentrate, can't sleep at night. And all these things are not good for one's psychological health, but also not good for the ability to stay healthy as long as possible physically either. So that kind of anxiety disorder, of course, worrying, feeling it physically, the emotions in one's body, all that can be helped with psychotherapy. And if psychotherapy is not helping, then certainly medication can help as well. And the medications can be almost what I call natural medications. Antidepressant class medications are just keeping your own serotonin levels at a higher level to help you. So they're very natural and very helpful. And then there's other medications to help with panic. With depression, similarly, if you sometimes just lose interest in things that used to be interesting to you, if you are not interested in getting up, it's a combination of sleeping too little or sleeping too much or back and forth. Eating too much or eating too little. Change in appetite, change in interest. Just not caring, thinking that the future is so terrible, there's no hope for any joy in the future. These kind of depressive thoughts. Again, I want to separate. It's natural to have some of these concerns at first after diagnosis. It's healthy to have these concerns at first because that spurs one into thinking, what can I do better? How can I adjust? But if it paralyzes one, then it requires clinical attention.
All right, thank you very much, Doctor. Then we're going to go to Dr. Borman in the center. I think she saw this one come in, but I'm going to go a little different direction. One of the things I really saw in the skit was a couple communicating. And communication is really essential. And it's not just between the couple, but it's also multidisciplinary, which is your specialty. Can you talk about communications and the things that we need, that people should be talking about?
Yes. I was so excited about today's presentation, not only that we get to be together and we get to be in the new courtyard, using it as was dreamed, but what I see in our topic today deals with my specialty of palliative medicine. And people make the mistake that palliative medicine equals hospice, but my definition is helping patients and families cope with serious illness at anywhere along that illness. This skit showed us that right at the time of the diagnosis, people are in distress. And one thing that's totally human is fear. We heard a lot of statements in the skit indicating fear. Sometimes they were labeled fear, but sometimes not. And even though fear is a 4-letter word, it's okay. We can use it. And I want you to know that there are 4 universal fears of being human beings. This is across all cultures. People are afraid of the unknown. And if we can provide anticipatory guidance about what may happen in the future, they feel a little better. People across the globe are worried about uncontrolled symptoms. And your healthcare provider is part of that team to treat depression, to treat anxiety, to treat the ultimate origin, Parkinson's disease. The third universal fear is abandonment. We heard I don't want people to not be with me, not care about me. So abandonment is big. And we also need to address the burden of illness. And there are many burdens that challenge flexibility. So fear is normal, it's human. And when I hear mental health problems or mental health challenges, what I'm really thinking is we're challenging your humanness. And I want everybody to know that regardless of your illness, you are the human being that you are. Illness can't steal that. So that's my starter.
Great. With those questions kind of setting the stage, I want to ask, is there anybody in the audience who would like to ask a question of one of our doctors? If you do, just please raise your hand. Okay. I think I see Mr. Tommy Henderson in the front. Do we have a mic for him, please? Go ahead, Tommy.
What do you do when your caregiver abandons you? Like, I was supposed to come here with my caregiver. We were living together in a relationship, and she said that she's going to the Big Island with a new male friend of hers, and he's going to spend the weekend with her. And I'm in a little bit distressed about it. We haven't really had the chance to get too intimate with each other, but nonetheless, we're on different paths now, and I want to know how to deal with it. You know.
Thank you. Did everyone hear that? Okay. Who would like to take that?
I'm sorry you're experiencing that. The first step in dealing with abandonment is recognizing that's what you feel and accepting that that's a universal fear. And one of the things I would encourage is enlarging your circle of care. Okay? It takes a village to take care of human beings. And although you're hurting and aching and fearful because this current care person can't handle it, there are still people that want to help you and may grow into that role, or they may care for you a little bit differently. But it does take time to heal from a wound like that.
I don't think this is on yet.
Oh, okay. Sound? I'll take that microphone. Sound, and we can go to the hard wires. Test 1, 2, 3, hardwire. Test 1, check. Cash, credit card, check. Bounce, check. Cancel, check. Okay.
Thank you. So, yeah, this is devastating when you, especially as you start feeling less capable in your life, feeling more helpless, believing you're more helpless, and feeling the ambiguity of depending on others. And it's confusing, it's terrifying when suddenly that other you're depending on is no longer there for whatever reason. Some people are there physically but not emotionally. Some people get burned out and say they can't take it and just separate. Some people just leave. And that's terrifying. So certainly recognizing the normalcy of that, admitting it, acknowledging it is a good start. I mean, it's real. And there's nothing to be ashamed of in feeling that. But then, in all situations, what's the best we can do, given our situation? What's the best we can do? recognizing that we want to be connected with others. So how can we join a group, get connected somehow, get services that we need to help us and not be ashamed of that? These are important things to recognize. Part of being human, as she said, is recognizing our humanness and not to be ashamed of wanting to have connections, grieving the loss, and then saying, what's the best I can do? I can seek connection however I can get it, because we need that. We're humans. We're pack animals. We need connection.
Thank you very much for the question and the answers. So now we're going to go out to Zoom. I understand Billy V's got a question coming in from that direction.
Thank you very much, Jerry. And this is, once again, from Zoom. In the skit, the caregiver seems to be in denial. I was diagnosed 18 months ago, and I seem to be the one in denial. Is this a depression issue, or is it just normal?
Yes, I think the skit, and first of all, I wanted to also comment on the other questions, and I really appreciate Jerry bringing this topic because I think it's one of the biggest elephant. And he said we'll go into dark, and it is true. It's a very difficult topic to acknowledge about these deep emotional fear, abandonment, sadness. And I completely agree with the wisdom of Dr. Borman and Dr. Spira about acknowledging it. I think it's okay. We don't have to cover up. Not everything is always okay. So acknowledging that is probably a first step. So in terms of the denial, I think we see it all the time. And that's partly, again, not everything is bad. Sometimes we are in denial because that's a defense mechanism. So we don't want to just label things too much, and maybe we might want to move on and go a little bit deeper. Why do you think you are in denial if you think that? Or I think what I would say is that these kind of venues are amazing because we get to connect and experience collective wisdom, find others that have similar problem. So it's the community that may help you, but at the same time, in the personal issues, is this denial, is this depression? I can't answer that without going a little deeper, so I would dig a little deeper, consult your physician, talk to your family, talk to your go to support groups, and kind of explore a little bit. But I think it is a good step that you're asking that question.
Great, thanks much. So I'm going to go off in a little bit different direction. I'm going to use my moderator prerogative. And in Parkinson's, it's very important that we do exercise. How does that play into the mental states and some of the challenges that we deal with in mental health? Anybody want to take a crack at that one?
Well, Parkinson's is not the only disease where exercise is prescribed. I'd like to emphasize that exercise is a proven thing to help with depression and mood. And it's hard to be anxious when you're exercising. So it serves so many purposes. But it is critical in Parkinson's disease. It is part of the treatment.
And yes, let me emphasize, if everyone exercised optimally every day to the extent that they're capable of, most of us would be out of jobs, and that would be okay, because then we'd get more chance to exercise too. It's not only good for, physiologically for our health, but as was indicated, attentionally. When you're exercising, you don't have time to worry. You're focused on interacting with the environment, and that's so critical for depression and anxiety and health in general. The more we interact with the environment, the less we get into these obsessive worried loops. So I cannot emphasize enough how important exercise is. And I know a lot of people, as the disease progresses, can't go run marathons, can't do their kung fu exercises every day, anything. anything. Tai Chi is wonderful. Yoga is wonderful. These things are fabulous. I've taught Tai Chi for Parkinson's for years, and just seeing how valuable even that can be, even though it's maybe not especially aerobic. Just paying attention to the movements, helping with balance, helping with smooth, calm movements is fabulous. So please engage in any activities you can.
Yes, just to be clear, it doesn't have to be high cardio, high intensity. The lower intensity stuff helps out as well.
Whatever one can do. If they're able to do aerobic, fabulous. But if not, that's fine.
We're not all Jimmy Choi's.
That's a fact. I broke a sweat just watching him last year. Do we have other questions from the audience? There's a question in the back.
1, 2, 3, microphone number 6. Test one,
you're
two,
good, Bill.
3, 4, 5, 6. There we go.
Do you have any recommendations? Do you have any recommendations for folks that can help them and their caregivers kind of identify that fine line between, a lot of times the anxiety and the depression, two pieces kind of mimic a little bit of Parkinson's symptoms, meaning you're tired, you wake up and you're tired, or you don't understand why you're having trouble moving or getting able to move because of the anxiety or the panic. Is there anything you can help folks just kind of delineate to know when they're crossing that line to tell the difference between kind of, okay, this is kind of normal Parkinson's or you're having a bad day versus, you know what, this might be more symptomatic of anxiety, which can then turn around and create these other symptoms that look like Parkinson's?
I would suggest that the source of the distress is, it's almost a moot point because Parkinson's has a known complication of depression and anxiety as part of the disease. Humans without Parkinson's can get anxiety and depression. These diseases can be lifelong and worse in this situation. So the bottom ultimate, what is the label, is not as important as getting help.
And in addition, no matter where one finds oneself, to always ask the question, what's the best I can do right now? What's the best I can do right now? If I'm just, I can't get up today. All right, in bed, what can I do? Can I move my legs side to side? Can I do breathing exercises? Can I, entertain myself in some way? What's the best I can do, no matter where I find myself, whatever the circumstances? Now, if you find that you can't even be asking that because you don't care, and this persists for some days, then you might want to seek some help for that.
Yes, I completely agree, and just wanted to add that Parkinson's symptoms can fluctuate a lot, as well as medication reaction. So sometimes if it fluctuates a lot or correlates with your medication timing, it might be a little more related to medication or Parkinson's. So it is also probably good to see the pattern, the daily pattern, timing, in addition to, ultimately, I agree with Dr. Borman that regardless, we want to get help and decide what you can do. But at the same time, kind of monitoring the timing with the medication might also be additional help.
Okay, great. I think we're going to go back out to faraway Zoom land for another question.
Thank you very much, Jerry. I am a caregiver in my 5th Parkinson's year. Can you hold that a little bit up? Sorry, oh no, that's, okay. Caregiver in my 5th Parkinson's year, and the reality of needing a caregiver is looming. I don't have a partner or kids. Can you please speak on what resources are available for single people with Parkinson's? Sorry, I think the word caregiver is in there. This person is in the 5th Parkinson's year, and they're looking for resources.
So in palliative medicine and my other specialty, geriatrics, resources are really important. We need to know our community, and we need to help people connect with what they need. One resource is the government agency, let me get it, it's AAA, the Area Agency on Aging is present in every geographical region. And they are the keeper of all resources for people who aren't able to care for themselves completely. So some of the resources, I'm not going to say specific resources, are hiring a care person, seeing if there's someone from your faith community or a group of people from your faith community that might be able to help. A huge point that I want to share with you is that it's okay to need help, to ask for help, and to accept help. And that includes help finding the help. So again, it comes back to a large circle. But the Area Agency on Aging in each region has what's called Senior Information and Assistance. And senior is broad because young Parkinson's, you may not feel like you're a senior, and that's okay, but you need help, and so you're vulnerable. So the Senior Information and Assistance, you can just Google that, and they are the keepers in your community of resources. You can reach out to associations like the Hawaii Parkinson's Association. You can reach out in care groups. Again, it's the ability to ask for the help. It's out there, we just need to find it.
And along
Jerry,
that,
are there any Parkinson's support groups going on right now?
there are. We've actually, across the state, we have approximately 13 actual support groups. Then we have other exercise groups and things like that. What I was going to recommend is get in touch with our resource center. Pat Bemis, who's our resource center manager, will help you get some of the resources that are available to us. Pat's wealth of information, working with AARP and a bunch of the other organizations, so we can try to help point you in the right direction for things like that. So we're going to move on a little bit. I'm going to ask one of the questions that I noticed during the skit, people kind of perked up about. It was intimacy. And it's for Parkinson's, a lot of people, it's a very difficult conversation to have with your partner, what's going to happen with your intimacy in the future. And then if you start having mental health challenges of different varieties, how does that affect it? So I'm going to actually kick this one to Dr. Spira first, because I know it's a very hard question. What can people expect to happen to their intimacy with their partner or spouse as these conditions progress?
Right. Well, with all chronic illness, there's going to be concerns on both parts, both partners. And in general, I think that intimacy is an important part of a relationship. So it's important to respect that and to try and encourage it if at all possible. I like to prescribe it for couples. Now, with that in mind, I think it's also important to have the Parkinson's patient kind of drive the mood. If they're not feeling it, okay, share that. Be open, be honest about it. And when they are feeling it, go for it. It's an important part of bonding, stress management, intimacy. So I think they need to be able to engage in that, continue that intimate relationship as long as they're interested and able to do so. Now, sometimes I've seen a dynamic happen that's very important to pay attention to. Sometimes the partner of the patient with Parkinson's is going to be a little hesitant, and then the patient with Parkinson's sees that. Oh, they're not interested, they think, because they're not really talking about it. And so the partner says, oh, they're not interested, so then I won't push it any further. And they go further and further away, right? Communication, dialogue, critical. So it's an important part of the relationship as long as they're able to engage in it. And to various ways of engaging in it, they should just be open and honest about it.
I'd like to emphasize that there are many forms of intimacy besides sex, okay? So some people, intimacy, that means we're having sexual intercourse. What about cuddling? Very powerful. What about just holding hands? What about just saying and meaning, I love you? I may not physically feel like sexual intercourse today, but I want you to be my intimate partner. How can we express that now? Think about the love between parents and their children. It's very intimate, and we hope it's not sexual. So with serious illness, we often have to reframe our hopes and dreams and reframe what we can do exercise-wise. But that's okay. We all have hopes. And with serious illness, we can reframe hope. No one can steal your hope. No one.
Doctor, and I want to make sure that our listening audience on Zoom, she said reframe, not refrain, reframe. It's very distinct differences, and through the mask it may not be heard, so I want to make sure that that's being said correctly.
Thank you.
Jerry?
Thanks, Billy. Go back to the audience. Anybody else have a question? I see Pat's hand coming up. Hold on a second, Pat. Got a mic coming towards you.
One of my frustrations as a caregiver or a care partner has been that there's, in our neuro visits with a physician, never has the question come up of, how are the two of you doing? And even the whole issue of intimacy's never been brought up. And when I started attending support groups and getting more information, I realized that it was a thing with Parkinson's. I thought it was us personally that didn't care, didn't find me attractive or any of those things, and I was afraid to put him in an awkward position. So we had a terrible time navigating alone doing that.
Yeah. Yes, thank you so much for bringing this up. And I am practicing neurology for over 15 years, almost 18 years. And I realized that actually I recognize that in our practice, our focus has been, the way we were trained is evidence-based medicine, prescribe medication, maybe offer surgery, check box, check symptoms. And I think with what I'm now realizing, and just a little plug to Queens Parkinson Movement Center, is that that's not enough. That's not what patients needs. That's not family needs. It's not patient-centered. The intimacy, relationship, life is what is more important. So I hear you, and I'm glad you raised it. Group like this, Hawaii Parkinson Association, and this kind of symposium where we bring these more true life issue, life problem, I hope we can change and learn from all of you. So I really appreciate that comment. I hope you can raise it with your doctors, because we want to learn. We're human too. And I think that's how we have to navigate living with Parkinson's.
And I think that the health professionals have to be the ones to initiate the conversation. Because if they're reticent to do so, the clients are going to be very reticent to do so. If they say, so how's your intimacy doing? How's your communication? Caregiver, do you get breaks? How are you doing? Don't be shy about taking breaks. You need to take breaks, because you won't be a very good caregiver if you don't. Are you guys driving each other nuts a little bit? I mean, you have to initiate these things, and then, believe me, they're going to be very happy to talk about it. But if you're a little reticent, no, they won't.
Thanks, Pat.
I think as medicine has advanced and gotten more technologic, so in our wearing our medical hat, we have to know a lot. There's a lot to consider and balance. I'm afraid that medicine has lost a little bit of humanness. You know, if we look back in the history of medicine, being supportive and emotional and helping people cope with their issues that was probably the best thing that was available. We didn't have antibiotics. We didn't know 15 medications that help with Parkinson's disease. And so doctors were very attuned to that. And I like to remember that people are whole, and it's better to know the person that has a disease than the disease a person has. Of course, it's best to know both. Yeah, this integration of what human nature is, doctors might not take as much time for that. And I think that's another feature that's very difficult in medicine is, can doctors take enough time to talk about intimacy? You can't rush it. And part of what I love about geriatrics is that the older people get, the slower they move, and I love that.
Thanks, Dr. Borman. We're down to one final question, and I've kind of brought it up in my initial remarks, but you've heard it from a number of people, and it's dealing with caregivers. We've talked a lot about patients and the challenges for the patients, and we've kind of referenced some of the caregivers and a couple of the challenges. The caregivers get depression as well. How often do the caregivers get depression, and how do we as patients help the caregivers with their challenges alongside while we're trying to deal with ours? It's a very challenge for a lot of us.
Family caregivers, we almost expect to have burnout. We expect it. They don't get a break unless they get permission to take a break. And we have to give them permission. You have to give yourselves permission, because otherwise you won't be as good a caregiver. You will burn out. You will be exhausted. You will be frustrated. You will be sad. You will get depression. So please take care of yourselves to be the best caregiver you can be. When the announcement comes, or if there's an emergency on the plane, the oxygen drops, you put it on yourself first. You've got to take care of yourself. You've got to take a little break every day. You've got to exercise, eat well, sleep well. And if you find you're trying but you can't, then you need support. You need help. Everyone needs help.
Yes, thank you so much. And I'm glad organization like Hawaii Parkinson Association is trying to address the caregiver issue, create a community. I often see dynamic, it's nobody's fault, but sometimes it gets frustrating where the communication and the relationship can become challenging. And without Parkinson's, sometimes I have challenge with my own relationship. So it's just always good to remember that it's sometimes the bad situation is nobody's fault. It's just a bad situation, and the best way to deal with is teaming, creating a team, and not just you as a sole caregiver, but creating, again, community and asking for help. So I completely agree with.
Caregivers are an integral part of what people with serious illness need. And I ask every visit, how are you doing, care partner, caregiver? Are you taking a break? Will you allow yourself to take a break? What are you doing to recharge your batteries? I want to emphasize that your loved one with Parkinson's or any other serious illness, there is a dependence on you, and so the person with the disease can only do their best to the ability that the caregiver is able to help. So protect your health. Caregiving, it's honestly a dangerous job in so many ways. There's a physical danger. Did you sprain your back? Did you fall in the corner of tripping over walkers and canes and all the assistive devices? It's known to be associated with a higher incidence of mental health challenges like depression. It's proven that caregivers have a higher incidence of medical conditions Now, maybe is this because they don't take time to care for themselves. They have more heart attacks. People who are caregivers have early death, to be honest with you. So live each moment. All we have is the now. So one of the themes in the skit was worrying about the future and reading about all the difficult challenges ahead. Well, we can't change whatever our future is. We can't even imagine how it will turn out. And the past being sad, and it's like, oh, I can't do this anymore. I can't do that anymore. The ability to maintain a positive mindset, to focus that the glass is half full, not half empty. I tell people with all types of serious illness, if you focus on what you lost, it's going to be kind of miserable. Please focus on what you have left and enjoy it today. We want you living while you're alive.
Thanks very much, Doc. So this brings us to the close of our first interactive session. Don't worry if you didn't get a chance to answer your question. We have, over the next 45 minutes, we're going to go ahead and take a break. We have some light snacks over here, water, hydrate. Up here, we have the Ask the Doctors subject matter expert area where Dr. Ross, Dr. Kanan, Dr. Lyman, and Dr. Rosenfeld will be up there. And then we'll get in, at 11 o'clock, we'll present the second skit. And afterwards, we'll have another session with our doctors back, talk to us some more, but more along the lines of advanced Parkinson's situation. Please be sure to go out and visit the Resource Center, take a tour down there. Tours will be leaving from over by the Hawaii Parkinson Association booth that's over there. If you want to take a walk down there and check out what resources we have, and get around to all our sponsors and vendors booths. They were kind enough to fund this event, to make this event possible, and to share themselves in their time with us. So with that, we're on break for 45 till 11 o'clock, and I'll turn it over to Mr. Billy.
Okay, hang on, everybody. Stay right there. Pat, you're actually in the perfect position standing. Take a look back towards camera. I'm going to answer one question that came in on Zoom real quickly. I am a physical therapist. I agree that depression is definitely an issue when this population is diagnosed. I have tried to connect my patients with counseling, but mental health providers are not many. Mental health providers are not taking new patients, especially after COVID. Is there a resource list of mental health providers that do work with Parkinson's who are taking new patients? Pat, go ahead and stand on up. Pat? Yeah, there you go. And Pat, you can look towards the back there. We got a camera on you. So this is Pat Bemis. She's with the Resource Center for Hawaii Parkinson's Association. So we would like to tell you, you can contact her, and she can go ahead and connect you to any resources. Right, Pat?
Yes, that would be great. If you call the Resource Center, and if we're not there, please leave a message, and we get back to you very quickly. And we'll talk with you to find out specifically what and who you're looking for to help you with the situation. Okay?
Pat, thank you very much. Ladies and gentlemen on the stage, please, one more time, a nice round of applause for Doctors Michiko Bruno, Jim Spira, and Pat Borman. Vendors, go ahead and head on back to your areas. La, 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 la. There we go. And for those of you that are here to take in today's symposium, you're more than welcome to go visit, as Jerry had mentioned. We are on break until 11 a.m., but we're going to do some interviews here as we continue things live from St. Francis Kupuna Village up in Liliha on the island of Oahu. We're going to go ahead and you're seeing a screen right now, but what we're going to do is we're going to move with our broadcast crew, and we're going to move to do a couple of interviews right now.
It's working the way I envisioned it. So.
We're going to come over here, and as a matter of fact, we're going to do an interview right now, and know that this is being done live, so that maybe people crossing behind, people crossing in front. What we're going to do is I'm going to have you hold that for me as we do our first interview. There are a couple of things I need to take care of. And Matt, you're going to open that for me. And I'm going to take the microphone here. Oh, actually, this one here. I'll hand it right back to you in a moment. Once again, we're live. And thank you so much. do me a favor, take that, wipe that microphone down, and you can hand it to our first guest. Thank you very much. Mahalo to our crew, and you guys are, come over here real quickly. You guys are from what part of the University of Hawaii?
We're from UH Manoa Pre-Medical Association.
Pre-Medical Association, they're assisting us today. Thank you guys. We'll introduce you on camera coming up in a couple of moments. Jerry Garcia, who of course, St. Francis Healthcare System of Hawaii. This is a wonderful area here, and as we talk, we can probably show some of this area here that we're speaking of. First of all, tell us about this area here.
So this is the courtyard for the Kupuna Village, and sometimes I refer to it as the pico of the campus, and it is the gathering place. It's the place where, there's a lot of education going on for the caregivers and the support groups, caregiver training. We've got cooking demonstration rooms, classroom participation, exercise classes. A lot of it is for the caregivers and the seniors and the support groups.
Explain Kupuna Village for those that are not familiar.
So St. Francis used to, at Liliha, there's an 8-acre campus. It used to be a hospital, a 255-bed hospital. And about 10 years ago, we revisioned the campus. We were no longer in the hospital business, and we revisioned the campus to be a campus that can serve the senior population and the caregiver population. And so we called it the Kupuna Village. We know that we want to take care of our seniors and our kupuna. And as we went down that path of figuring out the services on the campus, we discovered that the caregiver population is growing just as the kupuna population is growing, and our caregivers and our support groups need help. And it may be navigating. It may be, I'm a caregiver all of a sudden, and I don't know what's covered under my parents' Social Security benefits, their Medicaid benefits, what's out there, where are the services out there. And like the services for the Parkinson's Association, what I wanted to do on this campus, and that was the vision, was you come here, you get a class, you get some education, and it's on Parkinson's and how to take care of my dad with Parkinson's. And the first question after the class is finished is, where can I get that support? And I would love to say it's 30 yards away at the Parkinson's Resource Center. So having this be the place where a lot of these services can be accessed is really important.
All right. If somebody wants to find out more about what you do here, where can they find you online?
Well, stfrancishawaii.org or 547-6500.
All right. Once again, Jerry Correa joining us here at in the pico of Kupuna Village here. Thank you very much, sir.
No,
I'm going to ask my team here, and come on over, gang. Do me a favor, take his microphone, and you'll need to wipe that down again. I'm going to ask you to hold on to this. Come on over here with me a little bit, because I'm getting a chance to kind of reorganize from our stage presentation to our interview presentation. What I'm going to do is I'm going to tell our sound people that I'm going to turn on my lavalier mic that I'm actually wearing. That might help a little bit in keeping my hands free. So I'm going to turn that on. 2, 3, 4, 5, 6, 7, 8, 9, 10. And I'm testing that microphone on the lavalier. That's lavalier number 8. Test 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There we go, a little bit better. Okay, so that means we have one more microphone for you guys to hold on to. Can I have that sheet of paper for here? Okay, team, here's what we're going to do next. We have, and make sure that all of your microphones are off. We have the gang from Parkinson's Unit, Hawaii Pacific Neuroscience, Jessalyn Lee. Go ahead and find her and bring her to me. And also, we're going to see if Dr. Michiko Bruno is around. She was just here. I'm hoping she didn't leave. And Dr. Bruno, if you are within the sound of my voice, Dr. Bruno, come on over here in the broadcast area. Hi, Jessalyn, come on over here. You can step right over there. You'll be handed a microphone. And do me a favor, we're going to step right, the cameras are in that direction. You can wave hi. This is Jessalyn Lee. She is with Patient Experience, Parkinson's Research Unit at Hawaii Pacific Neuroscience. What is Hawaii Pacific Neuroscience?
Yes, so Hawaii Pacific Neuroscience, we are a comprehensive interdisciplinary clinic, and we are really multifaceted. So part of what we do is we are a doctor's office, we're a clinic. We do have many specialists. We do have a Parkinson's and movement disorder specialist. We also have specialists in Alzheimer's, dementia, sleep disorders, epilepsy, migraines, you name it. We have a specialist for you. The other aspect is we do have a wellness center. So on top of the medicinal side, we do have a specialist that helps to bring in that holistic component of healthy lifestyle, of what to eat, how to exercise, so how to management on the more naturalistic side. And then we also have a clinical research center. So we have over 30 active trials. So no longer are our Hawaii patients needing to fly to the mainland. We're bringing that here. We have a lot of Parkinson's research coming this year on top of the other diagnoses that I've mentioned earlier. And we're also teaching and learning facilities. So we really are here to be a resource to the community, to provide you with the medicinal care, but also the cutting edge research as well.
Got it. Now, if somebody wants more information, how do they find you?
Yes. So if you are looking for more information, you can call or text us at 808-261-4476. You can also email us at info, that's I-N-F-O, at hawaiineuroscience.com, and our website will be hawaiineuroscience.com.
Jessalyn, thank you very much for being with us.
Thank you, Billy. Appreciate it.
All right. We're going to go ahead and take care of that microphone. Meanwhile, Matthew will hand the microphone to our next guest. And Doctor, come on over.
Yes, hello,
We're going to put you right over here.
Thank you
And
so
sir,
much.
if you'd like to listen, you can, but I'm asking you to move right over there. Perfect. That way you're not in the camera shot. Dr. Michiko Bruno joins us here. She's the director of the Queens Parkinson's and Movement Disorder Center at the Queens Medical Center Neuroscience Institute. First of all, as a panelist, and I'll make sure that your microphone is on. Yeah, it is.
Sure.
How did you find today?
Thank you so much, Billy, and thank you so much for always helping. Your MC is so amazing, so I really enjoy it. But today, this was, well, first of all, great to meet in person after a few years, so in a beautiful setting like this. But I thought the session was so moving, raw, like it's authentic, based on real issues. Sometimes we can sugarcoat it, but it went deep, and I hope this helped a lot of people. I hope we can connect, because what I realized after practicing for so long is we can't do things alone. When we can connect with each other, it's much more powerful.
Tell us, first of all, about what you do over at Queens.
Yes, so we're very excited. I've been in private practice, but we formed this center a couple of years ago to have more comprehensive patient-centered care. So we have Brittany over there who is coordinating as a nurse and talking to family. We have physical therapy, occupational therapy, speech therapy. We have deep brain stimulation surgery. We do OPA. So we are doing a lot of advanced therapy, but at the same time trying to do a patient-centered care, comprehensive care with our care partners.
Awesome. Of course, very much team-based approach in this, right?
Exactly. We feel the need of being team as opposed to individual, yes.
If somebody wants more information, where can they get that?
Yes, please go to, first of all, we just updated our website, so if you could go to our website, Queens Neuroscience, Parkinson and Movement Disorder Center, you can probably Google that, but we also have a phone number, 691-8866. Again, that number is 691-8866, and please visit our website as well.
All right. Once again, Dr. Michiko Bruno, thank you so much for being with us today. Thank you, thank you. Okay, so team, thank you very much. Disinfect that. We'll get the next microphone ready, but let's go over to our other broadcast area, just because we're going to walk a little bit so you can kind of see everybody that is here, all the discussions that are going on. We talked to Jerry Correa. We're passing by his area here. And there are many people that are having conversations. And coming up in a couple of moments, we'll have somebody else also come on over to our area and talk some story here. So, Rebecca, thank you so much. And Rebecca's wanting to get one of these, a free alcohol. There we go. So while she takes care of the microphone and gets that ready, we will talk with our next guest and see if Ed Hunter is available. And Ed Hunter's right behind you, the gentleman sitting down there. We'll talk story with him. Once again, this is quite an area where we've got lots of vendors that are here that have information. And one of them coming up in just a couple of moments. Gavin Fukada, if you're also within the sound of my voice, Gavin, come on over to our area and we can talk some story with you. There we go. Ed Hunter is going to be joining us. Thank you, Ed. Either way, we'll leave the masks on.
Where am I looking?
The camera's over on the far side, so right there. Ed, you are with AbbVie Incorporated. Tell us a little bit about what brings you here and your connection to Parkinson's.
Yeah, so thank you very much.
Real close.
First off, thank you very much for having me, and hello to everyone out there. AbbVie is a biopharmaceutical company based in Chicago, Illinois. I live in Carlsbad, which is North County, San Diego. I cover responsible for San Diego, Palm Desert, and Hawaii.
Okay. Tell us about what you have and what you're talking about.
Yeah, so the product I have is called Duopa. Duopa is a medication for patients with advanced Parkinson's disease. It's really for patients who, after a number of years of oral medications, don't work the same. The oral medications are great. The problem or the challenge is the stomach. The stomach doesn't work like it once used to. They call that delayed gastric emptying. And with that comes a host of problems. So with Duopa, it's the same carbidopa, levodopa. It's a gel form, and it's administered with a pump, a portable pump that runs the medication through the tube to the lower intestine for 16 hours during the day.
Got it. The benefits of this are?
It's really a rather large reduction in off time when you look at the clinical trials. So patients are getting back more on time without the problem, some dyskinesia, and they're experiencing fewer off hours during the day. So with that, they get a better change in life.
If somebody is listening to this and wants to find out more information, how can they dive deep into this?
Yeah, so duopa.com. So Duopa is D-U-O-P-A. Duopa.com has a lot of information there. I would highly recommend going to that website and let that be your starting point.
All right. Once again, joining us here, Ed Hunter. Ed, thank you very, very much.
Thank you, Billy.
Good to have you here for the symposium.
Thank you so much.
Thank you, thank you. All right, there's some information for you. We're going to kind of slide on over here to this side. There we go. What we're going to do right next to us, of course, is where Jessalyn, we just had her on just a little bit ago. I think Kevin is free right here on the next table next to us. And we'll bring Kevin Lockett over and talk story about what he's doing and what they are doing here. And we'll go ahead and move kind of over on this side here. And Kevin, I'm going to ask you to come right up there and talk some story here. So Kevin, first of all, with Medtronic, you're a clinical specialist. Tell us about why you're here. But you also have a connection with Parkinson's Hawaii, correct?
Yes, yeah, I was a former president prior to Jerry for the Parkinson Association, and now I'm a volunteer. I've been running the Honolulu support group for some years now, and so and then before that, I'm a physical therapist focused on.
From the time that you were president, as you're seeing things progress, have things changed for the better? Has there been more knowledge? Has there been?
All of that, it's amazing, and just the awareness and the resources, and I've got to get a lot of credit to Jerry, even expanding and pulling in Hawaii to all these other national organizations to bring the resources here. So people are actually, when I go to the mainland and talk to other organizations, they're actually kind of shocked. They think that Hawaii is kind of third world, and there's actually the resources here, and with the formation not only of HPA's resource center, but also Queens Medical Center with now have Parkinson's disease specialty center. That the resources here are really equal to a lot that you'll see anywhere in the nation, I think.
Got it. Let's talk about specifically what you are here to do today.
So I work with Medtronic with deep brain stimulation, which is basically it's like a pacemaker. So instead of a pacemaker for your heart, it's a pacemaker for your brain. It helps with the motor symptoms of Parkinson's. And the unique feature for Medtronic is new technology that just came out is called brain sensing. So for the first time since this technology came out, we actually can get a window into the brain of what's going on chemically, and that information, the doctors can make adjustments to the stimulation, but also the medication to really optimize both therapies. So, yeah, it's continually advances. It's just crazy. Yeah.
Okay. If somebody wants more information on what you are doing here right now, how do they get that?
So they can talk to their physician, and they can get referred to a center. And right now it's Queens and Kaiser that do DBS and to do a workup. I'm also available to answer questions, and most of the doctors have my information. If not, I can be reached via my email. Probably best is kevin@medtronic.com. kevin@medtronic.com.
Kevin, thank you for past service and what you're currently doing now.
All right, thank you. Thank you so much.
All right. Kevin Lockett here. Once again, Medtronic. Thank you, sir. Medtronic Neuromodulation. Mahalo to them. Team, come on over here real quickly. And coming up, we are going to have a break. We're going to actually play some of the video from last year, Jimmy Choi. What we're going to do, I think we're going to go over to the far side, the opposite side again. And let me see. I'm going to ask you to stay with me. If you could go and see if Lynn Moku, Catholic Charities, she's on the opposite side on those tables there. And you know what? While we're here, Malia is with Hawaii Bicycling League. She is right there. So we'll get her before we go ahead and go holo back across to the other side. So while Malia makes her way over here, mahalo for watching. Once again, we are at the St. Francis area in Liliha on campus, and this is the Kupuna Village. Here comes Malia right now. Malia, thanks for joining us. I'm going to ask you to step up right here. Camera's right across. You can wave hi right there. There we go. Malia is the Director of Adult Education, Malia Harunaga from Hawaii Bicycling League. You're here at a Hawaii Parkinson's Association Symposium. How does this all tie in?
Yeah, we know that bicycling and obviously exercise is great for everybody,
right.
And especially those that are affected with different ailments. So it can actually help Parkinson's, and with something with the repetitious pedaling, every time you pedal, it can actually help you improve things like your gait and different aspects, even mental. So we're really all about bicycling, and we're a nonprofit just to try to get people into cycling. We really think that it's something that you can do at any age.
Okay. So when somebody contacts you, what kind of questions are you used to answering? What are some of the first questions they ask?
If I don't know how to ride a bike, how can I get riding? And we can absolutely help with that.
Okay. Some of the other questions you answer?
Some of the other questions, we're safe to ride. We have resources like a bike map. We have workshops to get people riding and feeling comfortable and confident on their either 2 wheels or 3 wheels.
Okay, and it's actually, we've had more bike lanes opening up in Honolulu.
Yes, yes, and all over the island. So Hawaii Bicycling League is the largest and oldest cycling advocacy group. So we're the ones that are pushing for those bike infrastructure and improvements to make the streets safer for everybody.
It's easy enough to say Oahu-centric, but you are mentioning that you are statewide helping people, correct?
We're on Oahu, so we mostly do things around Oahu, but we definitely have partners on the other islands, KOA Path, Hawaii Path as well,
nice.
That we partner together with.
Somebody wants more information on this, how do they contact you?
They can go to hbl.org, so that stands for Hawaii Bicycling League, hbl.org, and we have a lot of great resources and information there.
Okay, Malia Harunaga joining us here. Thank you so much.
Thank you.
I'll take that from you. I will fist bump you there. Go get them. Thank you very much. I'll hand that off. And we are going over, we'll go back over to the other side where we were. Sorry about that. Let's go ahead and take a walk. I'll hold on that. Thank you very much. We'll go, sorry, I wanted to go closer to you. Sorry, we'll go and walk this way. I changed that. Sorry about that. As we come across, Okay. Got it. We're here, right? Okay. We're going to come over here. Hi, gang. Norma, come on over here. You're right over here. And then microphone is working, so you can go ahead and talk into the microphone. Marilyn, Lynn, come on over. And Lynn, we are turning, and the camera's right over there. There we go on the far side. So Lynn Moku is the program volunteer coordinate for senior services for Catholic Charities of Hawaii. For somebody who's not familiar with Catholic Charities, explain.
Oh, Catholic Charities.
Real close. You're going to have to put that.
Catholic Charities is one of the oldest and largest community organizations. We have been in Hawaii for 75 years this year, celebrating, and service all islands. Variety of programs.
How bridge that connection for people between Hawaii Parkinson's Association and Catholic Charities? What brings you here to this?
Well, Catholic Charities is doing a lot of programs with dementia, people with dementia and family caregivers. We know that Parkinson's is one of those diseases that, like Alzheimer's, is progressive and people may have cognitive problems. So I see a real strong connection with the Parkinson's Association and our dementia programs.
When, usually they have a list of frequently asked questions when you go to somebody's website. What are some of the frequently asked questions that you get when people call?
Well, I work in the senior services division, so I get a lot of calls about the programs that we offer for seniors.
For Kupuna?
For Kupuna.
Such as?
Well, we have our senior center, Lanakila Multipurpose Senior Center. It's a place where seniors can go for services and camaraderie. Many programs, over 1,500 people are in that program. We also have benefits enrollment services to help people access services like SNAP or Medicare, other services. We have transportation services for seniors. You probably see the vans riding around town.
Definitely.
But we also have programs that I'm involved in is our Memory Mentor program. This is a program for people who have memory problems or dementia, where a volunteer can go into the home and have a friendly visit with them, help with grocery shopping, help them go through their mail, set up reminders. Eventually, we'll be prepping a light meal for them. We also have Phone a Friend for seniors who are living alone, isolated. This is a phone program where our volunteers will actually call and have that friendly conversation to eliminate, decrease loneliness and isolation.
And stress.
And stress, yes.
Awesome. If somebody is listening or watching this right now, wants more information on what Catholic Charities does, how do they reach you?
They can call our senior intake line, 527-4777.
And just a reminder, you do have to dial 808 now when you dial that number.
Oh, that's right, 808.
So once again, the number?
527-4777.
All right, once again, Marilyn joining us here, and thank you so much for everything that you do.
Thank you.
All right, we're going to have more. What we're going to do is we're going to take, and we'll take the microphone here. It's 10:45 right now, Hawaiian Standard Time. Coming up at 11 o'clock, we'll have another, and I think I'm far enough away from everybody else, I have my mask. Coming up, we'll have another skit presentation on the stage. And so that's coming up in 15 minutes. What we're going to do is we're going to give our crews a little bit of a break. But in the meantime, you get to watch from Jimmy Choi from last year, who was here with the Hawaii Parkinson's Association. Watch.
All right. Gee, man, I don't know. That's a hell of an introduction. I don't know if I can live up to all that. But you know what? Hey, guys, I just want to say good morning to everybody. Good afternoon from where I am. I'm in Chicago. I wanted to thank the HBA and all of the sponsors for allowing me this opportunity to share my story and experiences with all of you. Now, I know it's a crazy time we live in now, and, unfortunately, during these times of COVID-19, we're all forced to meet virtually, right? I mean, normally, excuse me, normally I get to interact with people in person, and when I get on stage, I get really nervous, and then I would use that age-old advice of imagining people in their underwear. Well, that's kind of hard to do virtually, since in this case, some of you are probably actually in your underwear, right? Now, I can't begin to tell you how disappointed we are not being there in person. The last time I was in Hawaii was 8 years ago with my family. And that was right after running my first ever marathon. And that was also 10 years into my diagnosis of Parkinson's. And for the first time in a long time, I was able to enjoy vacation with my family, where I thought more about creating memories and not about my symptoms if they were going to limit our family fun. You know, I want to show you some pictures from that vacation because we took some really scenic photos. So, you know, it's the first one. I remember the Locomoco. You know, that's beautiful scenery there. We don't get to see that a lot here in Chicago. The pulled pork and spam and rice. Oh man, I mean, look at that scenery there. The classic Hawaiian barbecue, you can't go wrong with that, right? Miles and miles and miles of shrimp truck along the North Shore. We must have stopped at every single one of those. And then, of course, my favorite is the hundreds of varieties of poke available. You know, all these memories of Hawaii, us mainlanders always say that you can't beat the scenery, but just look at that, what a view. And that was a great trip. I mean, all right, that's enough of beautiful sights of Hawaii. Today, I want to kick us off with a really short video, so let's take a look. There we go.
Just like everything in the 70s, I was made in Taiwan. My family immigrated to the United States when I was 10 years old. We moved to Bolingbrook, Illinois. I was very active in high school. I played multiple sports. I played baseball, I wrestled, and I was captain of the football team. I met Shiro in high school, and we got married in the year 2000. We have 2 kids, Mason and Karina. Life for us was just beginning. I mean, we had very ambitious career goals. I was very active. I played a lot of golf. Really, we were just getting into the groove of being adults. And then I was diagnosed with young onset Parkinson's at the age of 27. Four times what is 28?
7.
That's right. There you go. Nice. Mason, his smile can brighten up any room. Now, Karina, she's a chip off the old block. She loves obstacle course racing, and for fun, we watch American Ninja Warrior. Karina really got into the show, and every time the show comes on, she would say, "Dad, you should really try out. You should try to get on the show." I applied to make Karina happy. American Ninja Warrior actually called me, and they told me, "Hey, guess what? You've been selected to be a participant."
Jimmy Choi. He's a 41-year-old rookie who's also back.
Being on American Ninja Warrior is the most terrifying thing I've ever done, but it proved that I can follow my dreams and nothing can stop me.
Jimmy's story is an extreme example of the way the community is galvanized. Literally, everyone can't do what he did. I can't do it. But one reasonable answer to it is to get engaged in the community, get engaged in the fight, get engaged in research, get engaged in clinical trials. It's part of a call to involvement, and involvement has its own rewards.
I've learned there are positives and negatives to Parkinson's. People have said to me all the time, "Hey, Jimmy, you ran a marathon in 3 hours and 40 minutes. Can you imagine how fast you'd be without Parkinson's?" And I said, "I don't think I'd be running a marathon if I didn't have Parkinson's."
Jimmy Choi. He's running tonight for Team Fox. There's his wife and daughter, Karina, who got Jimmy to come out for this. You can see the trimmers in those hands. There he goes. Oh, Jimmy Choi. Woo! Nice grab.
All right, everybody. Once again, my name is Jimmy Choi. I'm 46 years old, and I was diagnosed with young onset Parkinson's 18 years ago at the young age of just 27. Now, the first question that people ask me, at such a young age, what prompted you to start your journey down your diagnosis? Well, it was actually a life insurance physical that started my road to diagnosis. The nurse that came and gave me a physical was taking notice of the way that I was moving, and she explained that she works part-time as an insurance nurse, but full-time in a neurologist's office. And she pointed out things that she said were very familiar with her in that office. Now, my story starts when I was only 27 years old. At that time, I was newly married, and I thought I knew it all, right? I would play golf, I would travel, I would start a family, have kids, boy and a girl. Yep, I had life all figured out. And then that nurse gave me a reason to wonder about all these little changes that I was feeling, like twitches, stiffness, and loss of balance. You know, all of those things could be explained away by an everyday life of a 27-year-old, right? I mean, the twitches comes from stress at work. Stiffness, I played a lot of golf back then, and carrying 40 pounds of clubs on your back 4 days a week, you're gonna be a little stiff. But still, she piqued my curiosity, and when she suggested that I talked to my doctor about what we discussed during our physical, then months later, after countless of visits to doctors and neurologists and movement disorder specialists and doing tests that I can only describe as sobriety-like, I found myself sitting in disbelief in my neurologist's office when I was finally told, Jimmy, you have Parkinson's. Now, it was actually a clinical diagnosis. My doctor's suspicions were supported by a positive reaction to medication, and then just a few years later, it was confirmed with 2 separate ZAT scans, taken 6 months apart, that indeed showed changes and decline in dopamine production in the brain. Now, up to this point, I was so sure that there was nothing wrong with me that I had not even mentioned any of this to my wife, Cheryl. I was in such denial that I kept it from her for another few months. Now, only when I decided that I would have to start taking medicine on a regular basis did I finally tell her. Now, medication allowed me to live life as usual. For now, it allowed me to ignore my progression. I did absolutely nothing. I didn't even do research or open that pamphlet that I was given on that first day. I wasted the first 8 years of my diagnosis trying to hide from Parkinson's. That's 8 years of time lost where I could have helped myself. But I couldn't hide much longer. My symptoms began to progress, and one by one, they became harder and harder to hide. Now, with each symptom, it was like extra weight or burden that I must carry just to lead a normal life. You know what? In fact, here, I'm going to switch camera angles so I can show you guys, because I brought these symptoms here with me to show you guys. So as you can see, I'm carrying this backpack. And in this backpack, I brought my symptoms. And these are the things that I was dealing with back when I was first diagnosed. So let's check it out, all right? Oh, now, each one of these symptoms, what I have here is a 10-pound weight that represents every single one of the symptoms that I was dealing with at the time. So let's see what we have. Insomnia. I had gait issues, problem with walking around, and problem with getting around, just even around the house. I've got a really crappy symptom, which was constipation. I had posture issues that I had to deal with. Executive functions, starting to lose some of those executive functions that I rely so much on, especially at work. Oh, Oh, look at this. Don't worry, we got more. Let's see, what else do we have? You know what? Dystonia. These cramps that come up and it can last for hours. I'm sure a lot of you guys know what I'm talking about. And then I got one more here, dyskinesia. Now this one is my favorite because this isn't even really a symptom of Parkinson's, but a side effect of all the medications that we take. The more we take, the more issues we might have with dyskinesia. Now, this is just an example of the weight that a person with Parkinson has to carry around. And these are just some of the physical symptoms of Parkinson's. We're not even talking about the non-physical Parkinson's, all the stuff that happens on the inside of our body that nobody can see. We're going to come back to this in just a little bit, all right? All right. Okay. So now to this point in my life, I was 35 years old, and I was carrying around all that extra burden. I was unable to hide my tremors. I was unable to sleep. I was unable to relax from stiffness and cramps. I was unable to write clearly or focus at work. I was unable to keep my cool, unable to smile. And worst of all, I was unable to play with my own kids. Now, it's gotten to the point where I had to use a cane to walk, and that led to a less active lifestyle. And I began to gain a lot of weight. Now, up until this point, I started gaining a lot of weight to the point where I was 240 pounds and I walked with a cane. And then frustration would set in. I was yelling and snapping at my family for no good reason at all. And when I yell, I could hear myself. Sometimes you have that out-of-body experience, right? I flew out of my body and I can see myself and hear myself screaming at my little 2-year-old daughter at the time. And what for? She spilled some milk or apple juice, right? And I always wanted to reach out and I wanted to stop myself, but I couldn't. Things were beginning to snowball and there had to be a breaking point, some type of rock bottom. That frustration I was talking about led to depression and it led to anger. All I knew was that at that time in my life, that was not the life that I intended to lead and certainly wasn't the life that I wanted to live. Now, as if that wasn't bad enough, in March of 2010, I did hit rock bottom. I was walking down the stairs with my then 10-month-old son, and suddenly I lost balance. Now, we both tumbled down an entire flight of stairs. Now, thankfully, I was able to hold Mason up high, and he didn't get hurt. I took the brunt of the fall, and although I only suffered minor bumps and bruises, mentally, I would never be the same. I knew then
La 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 la. Hi everybody, my microphone's on, which probably means that I'm probably also talking on the live stream while the video, oh, thank you very much. Hi gang.
For those of you that are watching, thank you so much for being with us here as we are at the Hawaii Parkinson Association Symposium 2022 as we come to you from Liliha area. What we've done is we've asked all of our vendors and all of our participants, oops, let me get back, thank you, Donald, to go ahead and take their seats so we can start the next skit. So as a matter of fact, we're waiting for our vendors and our participants. And Malia, thank you, come on in. But Malia, bring them with you. Bring all those people back with you over to the seating area. Yeah, just push them this way. Thank you. And let's see, over here on this side. Come on in, gang. We're going to start our next skit as our actor and actress comes up to the stage area. Jerry, did you want to jump in, or shall I just?
Please.
Oh, okay. Okay, very good. What we'll do is we'll have this skit, we'll have more talk story, we'll also have our doctors, our panelists come up and also take questions, answers. But for those of you that are watching online right now, just like the last time, keep those questions coming. We love answering them, or if not, then we will follow up and leave us your contact information or direct message the hosts, and then that way we can get to you at a better time. Here we go. As Jerry discussed, we have two scenarios today. The second scenario is based on a more advanced Parkinson's situation. It is written and directed by Alex Munro. And what I'd like to do is that Alex is probably nearby. Alex, where are you? Wait, sorry, right there. Ladies and gentlemen, Alex Munro, there we go, raising his hand in the back area. Those of you on camera, there he is. Paul is being performed by Matthew Kelty. Matthew. Eleanor is being performed by Christine Lamborn. So I will go ahead and set the scene for you. Some background to the scene. Paul and Eleanor are an average couple. They have been married a little over 30 plus years. They have two grown children not living at home. They made decent money and were looking forward to enjoying retirement. They were even thinking about retiring to the 9th island. Paul is in his early 60s, diagnosed 8 years ago in mid-50s. Is nearing the end of a good career in the hospitality industry where he spent the last 10 years as a supervisor. His job as a supervisor and company disabled accommodation policies allowed him to continue working. Doesn't smoke, drinks alcohol on special occasions, eats fairly healthy meals. Eleanor, early 60s, also nearing the end of a successful career as a CPA. Doesn't smoke, drinks alcohol at social events or levels, eats fairly healthy meals. Paul recently started seeing things that weren't there. Watch.
I saw a cat yesterday. The guys and I were having lunch at this place that's been really great about accommodating my needs. And all of a sudden, this cat jumped up on the table and started cleaning itself. Nearly flipped my plate. The guys seemed startled too. And Chris asked, "Was that your Parkinson's?" I laughed. "My Parkinson's? No, I just wasn't expecting a cat to jump up on our table." And then the guys grew silent as I reached out to pet it. And James asked, confused, "What cat?" And then I, in that moment, knew that Chris was right. It was my Parkinson's.
I wasn't there when Paul was diagnosed. I was at a conference in Omaha, of all places. He was so upset that I could barely make out what he was saying on the phone. I think we knew deep down what the tremor in his hand meant, but having it confirmed, it just opened the floodgates, so to speak. And then we went through the normal stages of grief, met with the doctors, signed him up for clinical trials, and after a few years of ups and downs, we found ourselves at not a stasis exactly, but a new normal. You know, I'll help him get dressed and eat his meals. He
He's pretty good about getting around with his cane, but sometimes he needs an extra arm to hold. And when he goes out on his weekly lunch with the guys, I try to get a little me time in. I'll go to get my hair done or go for a walk.
When you get diagnosed, they tell you that you might eventually start to see things that aren't there or confuse things that are there. Those Parkinson's books, there's this story about this woman who was talking to her houseplant because she thought that the leaves were green heads. She seems so calm in the story, like it's perfectly natural to talk to a row of tiny green heads. Even after they told her it was a plant, she just went back to finish the conversation. It just seemed absurd to me.
Sometimes I'll think back to before the Parkinson's, the things that we could do, going out to eat without having to constantly remind the waitstaff to only fill his cup up halfway, or needing to take his sticky placemats out to a fancy restaurant, or how we'd go on hikes around the island. Not that we were doing Cocoa Head every weekend or anything, but we'd get out and enjoy the scenery whenever we wanted to. Not whenever his Parkinson's allows. But then he'll laugh at himself as he drops some food off of his fork, and I am reminded that he is still that same vibrant, warm, strong, handsome man that I fell in love with and who's shared my bed for the last 38 years.
I even wondered if seeing things could be not a good thing per se, but like fun. Like, would it be so bad to see my kids sitting at the dinner table chatting about their lives? Some of the stories that other patients had sounded fascinating, like seeing beautiful art in your home. And then I saw the cat. And I think about how lucky I was to have been in a place that was relatively safe. I was sitting. I didn't stab myself with my fork. I was with friends who know about my condition. I recognized that I was having a hallucination and I could get help if I needed it. Like I said, lucky. But now I wonder what comes next. I know what comes next. Just like everything else with this disease, it's just going to keep getting worse.
He's still that vibrant, warm, strong, handsome man that I fell in love with and who shared my bed for the last 38 years. And he's suffering. He's been suffering, and now things are just getting worse. It used to be tolerable when it was just the physical challenges, but now he's starting to fall more, and his mind is starting to go, and I don't know if I can do this.
I tried to get Eleanor to talk with me about the end. She hates it. You'd think the CPA would like all the paperwork that comes with power of attorneys and living wills and all the other stuff you have to sign off on to die, but she can't handle it. And that's the thing that, look, I worry about the tremors and now the hallucinations, and I'm worried that I might eventually be trapped in my own body and mind. But at this moment, the thing that's most upsetting to me is that I can't help her. I know that I've been a burden on her, especially since the kids left, and I just want her to be okay.
And I know that makes me sound like a horrible person. I know it, and don't try to convince me otherwise. Here I am. I'm supposed to be looking forward to retiring, and I am dreading it because it means that I'm just gonna have to spend more time taking care of him. I mean, what kind of wife has those thoughts? And maybe I can't retire, not now, not with his Parkinson's getting bad. But Paul can retire. He's going to be forced to retire, more like, because he can't keep up at work anymore. But if he retires now, then how are we going to afford all of his bills?
Even though they're trying to force me out, I do still have some perks at the hotel. Maybe I should try to get us a nice staycation or something.
And I don't want to put him in a home. I can't imagine being without him, sleeping in an empty bed, but it's getting so much worse, and I'm so exhausted.
Maybe I should get her a staycation. You know, just let her hang out with her friends at the spa all day while she doesn't have to worry about helping me eat or get around the house. I could probably have the guys stay with me while she's out. It's got to be like living in a frat house again.
I'm exhausted. But he is suffering. I just know that I can't do this alone anymore.
We have a lot of hard decisions to make soon. But not today. There's a lot of living to do between now and then.
Paul? Paul? We need help. I need help.
Scene. Ladies and gentlemen, a nice round of applause. Matthew Kelty, Christine Lamborn. I'll give you a moment.
I'm good. Let's
You're
go.
good?
Yeah.
I'd like
It's acting.
I'd like you to both to introduce yourselves and say a little bit about yourself.
Of course.
Go ahead.
Oh, thank you. Hi, everyone. My name's Christine. I am an actress and educator here in Hawaii. I graduated from UH Manoa with a Master of Fine Arts degree in theater performance, and I'm just so honored to be here with you all today to have a breakthrough for starting a difficult conversation. So thank you for having us.
Hi. Hi, I'm Matthew Kelty. I have an MFA in playwriting and acting from the New School in New York, and I'm currently a PhD student in Asian performance at the University of Hawaii at Manoa, and the artistic director of the Oahu Fringe Festival. And just want to thank all of you for allowing us to be here today and for being so supportive. Thank you so much.
One more time, ladies and gentlemen, a nice round of applause for Matthew Kelty, Christine Lamborn, director Alex Munro.
Thank you.
Thank you so much. So what we're going to do is we're going to bring our panelists back up onto the stage, and I'm going to put them over here. And doctors, yeah, thank you very much. They're on the way up. And I'm just going to have you just hang on to them. Yeah.
2 and 3. Okay. Thanks, Billy, for getting us going again. And thanks to the actors and director for another great skit. Hallucinations refer to seeing or hearing things that aren't there. Delusions refer to believing things that are not true. The presence of hallucinations and delusions is technically known as psychosis. These symptoms may range from mild to severe. So kind of start off like I did last time for Dr. Bruno. How common are hallucinations and delusions in Parkinson patients that you see?
No switch.
Yes, yes, thank you so much. Again, a riveting performance and amazing script that is very realistic. Even before just talking about how common it is, I just want to speak medically a little bit about hallucination for the origin of hallucination. I think the hallucination and the delusions could be a little complicated in its origin. So as Parkinson progress, there might be some degeneration in parts of the brain that can contribute to hallucinations and paranoias, but also medication. Some of the medication that's used in Parkinson's disease, which increases dopamine level in the brain, can also bring about hallucination. And some medications are more common to cause hallucinations than others, but a lot of them can. So the incidence could be somewhat confusing, but again, I'm not just bringing this number 50 all the time, but up to 50% of people can at some point experience hallucination. It's a little more common later in the disease, but it could also happen earlier depending on the medication. Sometimes it goes away with decreasing the medication, but sometimes even if you reduce the medication or eliminate it, it could still be there. So it's a very complicated topic. But it's good to, I think in the past, as with the other skit, in the past, we tend to, as a neurologist, we tend to not bring it or ask until the patient or family brought it up, but we're now increasingly recognizing that very mild form of hallucination, just seeing shadows or little, shapes could be very common. So we're trying to bring the awareness and effort to bring it about.
Thank you. Again, I understand there's different types of hallucinations. We've been talking visual hallucinations, but Dr. Spira, could you talk about some of the other types of hallucinations there are?
Sure. I mean, as you mentioned, you read the definition. I thought that was very comprehensive. Thank you. There's visual hallucinations that can be as subtle, as the doctor said, as a shadow. What was that? Who was that? There could be someone sitting I think they're sitting over there. Is that a person? Why are they looking at me? So there can be suspicions. You can see something that actually might be there actually as a shadow, but then you interpret it as something that's not there, right? So it can go as extreme as actually seeing something, and usually this is if there's more advanced brain damage or if there's a lot of medication that's causing it. So in more rare cases or more advanced cases, you can actually see an actual person or thing there that's not there, that no one else can see. But that's more rare. Usually, as was suggested, it could just be like a shadow. It could be, this is the visual, and it's usually the interpretation that is confusing. You can also get very commonly auditory hallucinations. Again, a sound, was that a whisper? Why are they talking about me? Why are they gossiping? I don't like that. What are they saying? Again, it's kind of a blend between perhaps something that actually is heard and then your interpretation of what it could be. And then in more advanced stages, it could actually be voices that are external to me. Or in some extreme cases, it could be voices that are inside my head, but it's not my voice. They could be commanding me actually to do something. But again, that's more rare in this kind of situation. So that whole continuum. The difficulty with such hallucinations or delusions, as was pointed out by Jerry, belief about something, you get a fixated, obsessive belief about something that no one else thinks is actually happening. My wife is cheating on me. Why are you cheating on me? She's with me all the time, but she's cheating with me. Cheating with the physical therapist. She's cheating with the milkman, when there used to be a milkman. So things that, clearly cannot be the case, but I get obsessive and I believe it. Well, with hallucinations, there's a kind of obsessive belief about it too, and this is what's so difficult. It didn't come through so much in this skit, but in in reality, what happens is it's hard to try and convince the person that they're not having that delusion or hallucination because they really believe it. They actually see it. They see it like I'm seeing you. And you're telling me you're not there, or they're telling me you're not there. They're wrong. Why can't they see it? Or is there a conspiracy that they're trying to convince me that I don't see what I see, hear what I hear, know what I know? This is the insidious aspect of this problem. And sometimes it can be as simple as lowering the medication and it goes away. Sometimes you have to add a different medication to control it. But I'll tell you, just trying to convince the person or enter into the delusion with them is not the right way to go.
One of the interesting things I read talked about hallucination delusions of smell. And smell is, I mean, it's so nebulous to begin with. It's kind of, when do you know it's a hallucination or delusion? When do you know it's not real? When does, because at the beginning you have some insight that says, yeah, you kind of recognize it's not real, but when does that stop and you start actually believing it?
That's the problem. And smell is particularly interesting with Parkinson's. Maybe you want to talk a little bit about that as a precursor or an early detection.
Yes, thank you. So in Parkinson's, it is known that the smell sensation you can start losing smell sensation with a degeneration of olfactory bulb, even before you start to have tremor. And that doesn't mean just because you lose smell that you're 100% going to get Parkinson's, because there are many reasons to lose smell. So I just want to clarify that just because you have decreased smell doesn't equal to Parkinson's. You could have COVID or something else. But in Parkinson's, the degeneration could potentially happen, so you could potentially lose smell. And the smell control area is very close to the emotional part of the brain as well. So I think you could also have hallucination where you start to smell. Anytime there's an absence of sensory input, like visual loss or hearing loss, the brain sometimes try to make up a little bit. So that could contribute to some hallucinations, delusions, and so the absence of smell can also later lead to some weird smell sensation.
And this is critical. This is kind of complementing the delusional hallucination. It's not quite the same, but this filling in, we have loss of hearing, and sometimes you get tinnitus or you get sensitivity. The brain compensates, like she was saying, in smell, but it happens with memory loss too. As people start progressing in normal aging or dementia from any cause, people start filling in with their brains and often will start filling in ways that other people don't understand why they're telling that story to themselves. So it's not quite delusion or hallucination, it's kind of normal higher brain processes, but it can look very confusing to people. Like, no, that didn't happen. Why did you think that happened?
So of course, I love Dr. Bruno's comment that it can be the disease, it can be the medications. But the question I ask, is it causing distress? Does it impact comfort or safety? We may not be able to get our patients to the point where they don't have any hallucinations. We want to try to look for non-drug methods to treat, or adjusting drugs rather than just adding drugs. I try to teach my families there really is no reason to try to convince your loved one that the hallucination is not real. It is to them. So this confrontation, no it's not, yes it is, no it's not there, yes it is, it doesn't work, it doesn't help. And that's hard. We're used to being exacting and correct. And instead, are these hallucinations making them anxious, fearful? Are they grabbing knives from the kitchen? Then we really need to have to do something, right? Another situation I face in hallucinations is if someone lives in congregate care, like an assisted living or an adult residential care home, is it freaking out the others, the other residents? Because we have to protect their wellness as well. And these events with hallucinations and delusions, they can threaten the ability for a person to live where they're living. Huge. The stakes are high.
Yeah, very interesting, very great discussion. We have a question from Zoom land. So, Bill, if you'll relay that for us.
Thank you very much, Jerry. Here we go. I opted for DBS and am not taking levodopa. Am I less likely to experience hallucinations?
Yes, thank you so much for that question. So the L-DOPA, increasing dopamine level in the brain tends to exacerbate hallucination. So one of the reasons sometimes we opt for deep brain stimulation is decreasing side effect, not just hallucination, but any L-DOPA is a wonderful medication, but sometimes there is a limitation with side effect, as well as sometimes motor complication wearing off. So sometimes that is the reason we consider deep brain stimulation, not only, but that is one of the reasons. So in general, opting for deep brain stimulation might reduce the chance of having hallucination, but would not eliminate. I have, unfortunately, patients with DBS who still have hallucinations. But in general, deep brain stimulation tends to be a little bit of a lesser cause of hallucination compared to L-DOPA.
Thank you much. Do we have any questions from the audience here? Anybody? A lot of people think about it. A couple of years ago, when I was doing a presentation to a support group, one of the interesting things happened was there was a woman her mother had Parkinson's and she was experiencing severe delusions where she would keep knives and machete under her pillow. And so when they went to, when they go to wake her up, they would have to stand across the room and kind of wake her up. And they would, when she was in the shower or going to the bathroom, they would try to take those weapons away. But she would always find another one because they lived in the country. So the question is, for her is, what can I do? What can I do? They were getting to the point where they were almost deathly afraid of being around her because the hallucinations, delusions were so real.
Yes, and they should be afraid of being around her if she has knives and machetes, because the hallucinations are real to her, and she could be acting. I just interviewed a patient at OCCC, a patient, I'm a doctor, so I think, an inmate at OCCC who killed his fiancée because he was convinced she was trying to kill him, and she wasn't, it turns out, but because he was schizophrenic and having these hallucinations, he really believed it and had to act on it. That's rare. Most people don't really try and hurt you. It's more conspiracies and concerns and worries, like why are you cheating on me, or why are you all against me or something. And part of it too is my loss of self-control, my loss of independence. Just with normal aging, people are going to complain about this too. I don't want to have people take care of me even though I need people to take care of me. There's natural existential concerns here. But then when you get a little disinhibited, the dopamine's a little too high or whatever happens, the brain's not operating, the front of the brain's maybe not operating as clearly as it used to. Whatever little feelings become big and externalized and believed. So you don't want to, I really found this out the hard way, but it's a truism in my field. Don't enter into the delusion with them. Don't support it. Don't play along with them. It doesn't help. What you can do is say, I know you seem very distressed about your concerns. You seem very concerned, very distressed, very uncomfortable. Is there some way I can help you relax? Let's maybe take some medicine, go see the doctor to help you feel more comfortable about this. But absolutely, if there's any weapons around, take them away. That's not good in this kind of scenario. Whatever it takes, do not have weapons available. They could hurt themselves, and it's not their fault.
I guess we all have our guns and knife stories. I had an 86-year-old lady who Yes, was getting the knives. Yes, thought people were harming her. And she attacked the driver of the car, her son. There was a special needs daughter at home. She was threatened. And it's so hard to get these people care. I sent them to the emergency room, and because hallucinations are intermittent, she was not admitted. Oh, she's 86, she's fine. I couldn't believe it. She even had a psychiatrist on her case. And I called the psychiatrist and said, I can't believe this, that they would send her home. So it's very hard to get help because they're intermittent and, you know, it may be an 86-year-old little old lady. Well, that's ridiculous. It's a little old lady. But they're so real and can be so dangerous.
And they can pull it together for a few minutes. When they have to, when the environment changes, when they orient, they can usually organize it, and then the police or the ER, even a psychiatrist that should know better, can say, well, there's no justification for me holding them then, and they send them home. But documentation helps, video helps, other people's comments help. That will help the ER and the police and the psychiatrist justify treating them.
So I think what I'm really hearing is the single most important thing is take some action. You just can't let these conditions just kind of run their own course. You need something that needs to be done.
They usually are able to be helped to some extent.
Yeah, I'm going to go back to Billy for the next question.
Test 1, 2. Thank you very much. My last visit with my doctor, he informed me that I'm entering the second stage of Parkinson's, 6 years after diagnosis. Is it in the second stage that hallucinations start, or is it later stages?
One of my fascinations with Parkinson's disease is the symptoms can arise at any point. There's not a specific organized order. And maybe Dr. Bruno can speak to that.
Yes, thank you so much. I actually get asked a lot what stage I am in. And it's hard to answer that question because there are stages, Hawaiian stages, which is based more on research, and I don't find it as practical. We can categorize them in stages based on motor function, but as we are discussing right now, non-motor function, no motor symptoms, including hallucinations, but depression, anxiety, as we talked earlier, cognitive or autonomic, constipation, all of these could be quite disabling. So there's a general idea that some symptoms are a little bit earlier than later, and like smell is a little bit earlier. Mild cognitive processing is probably a little more earlier than later fulminant hallucination or dementia severe. But as we discussed, you can have hallucination quite early from side effect of medication, depending on your fatigue level, sleep level. As we all know, symptoms can fluctuate. So again, it goes back to not everybody have exact same symptoms. It doesn't always come linear, but by taking care of our brain health, rest, exercise, all those things can definitely help at any stage.
Great, thanks. Now let me check back in with the audience. Anybody in the audience have a question? Mr. Tommy.
Well, one thing that I've learned when I did my degree in psychology is to have a person take and delineate clearly what they see in the illusion. In other words, is the cat orange? Is the cat gray? Is the cat black? And how big is the cat? And looking at it from that vantage point, you can get them to see more clearly what they see. I mean, instead of just denying they're seeing it, they can actually classify and categorize the size and the weight of the cat or whatever it is that they see. So, do you have any wisdom about that?
Well, it plays partly maybe early on, or if there's not too cognitive impairment, some have insight that this is not real. Wait a minute, a cat on the table? But later in the disease, they may not. So it comes back to you, don't feed the delusion. So it's hard to know when that can be the right approach or not.
But I like the way you're framing it, that if it's early on, if they have enough kind of separate cognitive reflective ability, then maybe you could challenge it a little bit. But at some point, I think it is not beneficial to do that, because they think you're encouraging it, and then they get excited about it and get more into it. So early on, that might be useful to challenge it.
I want to also comment on this, that I agree with both of the panelists that sometimes when we start discussing the detail of the symptoms or increased medicine, decreased medication, get a little bit confused. So what I like to do is step back and discuss what our goal is. What is the most realistic, best goal that we can have together as a team, as a patient, caregiver, and me. So as Dr. Borman said, it might not be 100% eliminating all hallucinations. That might not be possible. It might be safety. It might be addressing distress. So we have limited time in the office, but rather than going into like detail of the symptoms and dissecting it, we want to kind of step back. It's a very difficult situation, so we just kind of want to step back and focus a little bit on the bigger goals.
Great, thanks, Doc. Any other questions from the audience? If not, oh, here, one over here on the right side, please.
So, regarding the delusions, so sometimes, like what if they see ants, right? But there's no ants. How do you phrase it to them that, there's no ants over there, or?
I always go back to comfort and safety. And it's kind of like what Dr. Bruno said is, what is the goal? People want to be comfortable. They want to be safe. If there's hallucinations about ants, don't worry, we can take care of that. Don't worry, we'll support you, and the ants won't win. Reassure them that they're okay. Don't engage the ants. Don't go reach for the Raid, the Raid spray. But get to the emotion. Are you afraid of this? We can help that fear. And how do we treat fear? Comfort, closeness, human contact. I'm always looking for non-drug therapy. We know it's important in Parkinson's because the medicines can have bad side effects. But part of my fascination and challenge in medicine is not only is the patient not following the textbook about when hallucinations happen or when that happens, the real truth is there isn't even a textbook. People are so unique. We really have to be able to think outside of the box. But, ants, like, well, let's wear long sleeves so they can't get your arms. You're safe in bed. We're going to pull up the covers. We have to think outside of the box.
Well, and something I like to do from maybe you probably all heard the term mindfulness meditation. I think that it's, again, you don't want to encourage them about the neighbors gossiping about them or the ants crawling on them. But I often say, oh yes, you seem to be distressed about that, but even if they are whispering about you, so what? It doesn't need to bother you. Let them whisper if they, I don't know that they are, but if they are, so what? Let that go. Learn to relax. Learn to be where you are, as comfortable in this moment as you can be. So let's learn to disengage from your worries, calm yourself. And then even if they were, that's their problem, not yours. Even if there are ants, so what? It's okay. it doesn't need to bother you.
Yes, I actually completely echo that, but I wanted to add one practical script. Sometimes this is what my husband does to me when I'm anxious or angry, is would you like a cookie? So distract them a little bit and just talk about something else. I mean, that doesn't always 100% work, but rather than saying, I think your question, the answer to your question is, it doesn't really help to say there's no ants. That doesn't get you anywhere. So rather than going into that, ask about emotion or distract or talk about something else. So not directly, not agreeing that there is an ant, but also confronting, neither of those help.
I think we have a question over here to the right.
Aloha, my name is Norma Kopp, Senior Medicare Patrol Hawaii Director with the Department of Health, Executive Office on Aging. Mahalo, Mr. and Mrs. Jerry Boster, for all of this and all of the team who put this together. So my question is two-part. Number one, why were you turned on in this area of medicine? Number two, thinking outside the box. What is happening with Parkinson's as far as future trends and how we can kako and help people here in Hawaii?
Hold on the second part. I'm actually ask you to defer that to Dr. Ross. He's going to have a presentation on that after this one, and specifically addressing it. To the first part, I'll let the doctors go ahead and answer what turned you on to this field study.
Okay. I became a health and medical psychologist because I find that people who are facing life-threatening illness are the most real people I ever interact with. They have the ability to look at their life, as the skits showed, it's raw, it's critical. They have to say, what's my life about now? And I find that these individuals have the best opportunity to determine how they want to be going forward, within limits, within the physical limits available. But these people, more than any others, have the opportunity to say, how do I want to live the fullest life I can in the time I have left, moving forward? And I just love to be a part of that.
I think it depends on what day it is, what I say draws me to this work. But the humanness, I think it's the miraculous thing of life. It's so different, it's so unique. Every person is different. I mean, look at siblings. You have maybe 3 children in the family, raised, bred of the same mom and dad, raised in the same household, and they're each so unique. So that uniqueness and the miracle of life, I love it. I love life. And certainly helping, it matters. Sometimes my specialty is asking questions that I don't have the answer to. They say in law that never ask a question that you don't know the answer to. But because we're trying to get at goals and values, like Dr. Spira mentioned, it's like, how do you want to spend the time you have left? What's important now? And these challenges of serious illness help us say, well, if I only have X amount of time, and sometimes the doctor's specific. I mean, in my work in hospice, it's like, what if you only have 6 months left? How do you want to spend it? Then let's make that happen. How can I support your goals? So it's different for each person. Each person is different. I just love how unique and miraculous life is.
Yes, it's hard to top both of those answers, and I completely agree, but I'm specializing in Parkinson's. So I just want to talk a little bit about what specifically Parkinson's drew me. So this was in medical school. I was rounding with my professor. I saw a very disabled Parkinson patient who could barely walk, and my professor threw a ball at him, which was very scary. Everybody gasped, but he caught it. And so the brain is an amazing organ, and in Parkinson's, I think we all know this, there is ability somewhere deep that you can still do things. And everybody with Parkinson's knows that some days are good, some days are bad. how can we bring about that goodness? Their good days. How could we? There's potential. It's slightly different from a different kind of disease where you're completely you lose complete ability. Parkinson patients live a long time and able to function okay. So how can we bring about the best in various different ways? So I think that's what drew me to Parkinson's, and knowing, patients and families for a long time is very inspiring. I learned so much and make connections. So I think that's very inspiring to me.
Thanks very much for those very open and honest answers. I want to get back a little bit to our topic that we kind of started off with, because I came across a kind of a unique one. We've talked a lot about how people get distressed by the hallucinations and delusions and want to get them back to a comfort spot. But what about the kind of unique patient who doesn't seem concerned about having delusions or hallucinations? They're just like, eh. So what do you do with them? Do you worry about them? Or do you just kind of let them go and enjoy their hallucinations?
Okay, I'm going to answer this. Okay, so yes, delusions and hallucinations very common. So I think the first question we want to ask is how distressing it is. And if it's not as distressing to the patient and family, sometimes it is education that this happens. And if the family and the patient can't cope with it, we don't necessarily have to jump in with a knee-jerk reaction to put them on medication or freak out. So if they can deal with it, I think that's, as long as it's safe and not distressing, we may have to accept some degree of hallucinations.
Great, thanks. Go ahead, Pat. Dr. Borman.
Well, yeah, I'm sounding like a broken record, but it comes back to comfort and safety. If the person is comfortable who's having the hallucinations, what a blessing, they're not uncomfortable. But we have to provide the anticipatory guidance for their circle of care. This happens. If your loved one is not distressed and it's not dangerous, then you don't have to be distressed. You don't have to make an emergency of it.
Sometimes they can be beautiful. When my mother was in her last week or two of life, she was seeing her husband. She was seeing her father, her brother. She was having conversations. That was beautiful. People would come to me and say, "Oh, I'm so worried your mom is..." I said, "What's to worry? It's nice. She's connecting." So yes, if there's no problem, there's no problem,
Great, thanks. Bill, I think you had another question from Zoom, or do you want me to go ahead and take that? No, I'll go ahead. I got you. The question was, please speak about REM disorders.
Okay, so REM sleep behavior disorder is slightly different from hallucination. When I ask people, do you have hallucinations? Some people say in dreams, or people enact dreams, and that's slightly different from hallucination in terms of medical definition. But anyway, when we sleep, when we sleep, we go into different stage of sleep, from light to deep, and at the end of the sleep cycle, we have something called REM sleep behavior disorder. I'm getting confused. REM sleep behavior. Okay, so during REM sleep cycle, we dream. That's the time that we dream. And normally, we're paralyzed because we don't necessarily want to act out or dream. When we're in REM sleep, sometimes the dream feel pretty real because part of our brain is awake. So we're normally paralyzed. And in addition, a lot of our dreams are bad, actually. A lot of people say, I have bad dreams. But the function of the dream and sleep is to reorganize our memory. So a lot of dream is bad and distressing. So normally we're paralyzed, but in REM sleep behavior disorder, which is very common in Parkinson, the paralysis is not complete. So what that means is naturally people start reacting to dream, start talking, start kicking, start punching their spouse maybe, try jump out of the bed, start running, sometimes trying to strangle the bed partners. So that is dream enactment.
Great, thank you very much.
And can I ask a question, follow up to that? Is it the case that persons with Parkinson's sometimes have an increased level or rate of prevalence of nightmares?
Sorry, yes. Yeah, so the question, if they have more nightmares is a good, we don't 100% have data on this that I know of, but some of the medication can make the dream a little bit vivid. The dopamine is medication that we prescribe for Parkinson can make the dream a little more vivid, and already at baseline most dreams are bad in terms of ratio, so then they've experienced it more real. So I think that's general consensus.
So when I tell people their potential side effect of this medicine or illness could be that your dreams are more intense, they ask me, well, is that bad? And ever the optimist, well, if you dream of butterflies and rainbows, wouldn't that be wonderful if it was more intense? But if you're back in your military or dealing with things that are stressful and icky, then no, we want to try to address that.
And from a self-help standpoint, there are medicines that can help. The Seroquel used to be given. I don't know if it's still given for that, and other prazosin and things might be given. But even before medicines are attempted to try and help with that kind of thing, I try and train people in, for example, meditation, relaxation. If they practice meditation, relaxation every day, then when they wake up from a nightmare or some disturbance, they can say, that was a dream, that was not real, this is real, calm my body, focus my mind. The more people can practice self-soothing during the day on a regular basis, the more they can apply it when they need it.
Thanks for the answers. The one thing that I've heard a couple times recently is medications. So the question is, are there problems with interactions between the Parkinson's meds and the antipsychotics?
Yes, thank you so much for that question. So first of all, I want to say the list of medication is ever growing, so it's getting more and more complex. But in general, Parkinson medications tend to increase the dopamine, whereas antipsychotic tend to decrease the dopamine level. So there is some conflict, innate conflict. However, the level of dopamine blockade in antipsychotic is variable in different medication. So in general, we like to try to avoid antipsychotic or antiemetic if possible when you have Parkinson's disease. And that's why it's so important for you to, whenever you start new medication, we really want to know about that. Call us and let us know when you go to surgery, when you go to hospital. Those are all very important time. But anyway, so we generally, if possible, want to avoid antipsychotic, but at the same time, everybody's different. Sometimes we need to use antipsychotic. We try to use something like Seroquel, as Dr. Spira mentioned, which has a little bit lesser dopamine blockade. So in certain situations, we would have to, and again, this is overall if the benefit outweighed the risk. There's usually no perfect 100% solution. We want to just kind of balance the benefit and the risk and come up to a group solution that we can work on. And that could be also, we might not be able to come up with solution with just one change or one visit. It might take a little work and feedback.
Thanks.
So it's really important to coordinate with your neurologist, because some other generalists might not understand, like the antiemetics, or if you have some movement disorder, they might give you something to help with that, but it might not work well with the Parkinson's medicines.
So I'd like to participate in the answer that my colleagues have done very well in answering and say, can we do something non-pharmacologic to help? And I believe the answer is always yes. We can focus on the unique strengths of that human being. Who are you? What will help you cope? I can't assume to know that, but can we draw the strengths of this person out to help? No drugs. Focusing on relationships, okay? Love is the strongest medicine I know. And if we can strengthen relationships, we are social beings. We need human interaction. It helps people feel better. It's not a drug. It's pretty darn safe. Dr. Spear has mentioned several times the be here now. Focus on the now. We don't know or control all of the future, and we can't change the past. We have the now, and we want to be living while we're alive. Focus on planning does really help, but only planning what we can take care of. Planning helps avoid chaos. We can plan our advance directive. We can plan wills and estates and trusts to make sure we're not leaving a burden. But we can't really plan how the disease is going to unfold. So let's move our focus to what we can do something about. I like your phrase, make our best choices. And one of the things that Dr. Bruno said, she said, well, Parkinson's is so variable. It is a roller coaster. And Jerry says it a lot too. You don't know what kind of day it's going to be. So how can we get through that? Because we're not going to get over it. That's the disease. It's going to be like that. I try to stay positive and I say, we know there are going to be bad days. But I don't say it that way. I say, fortunately, there's going to be some good days. Enjoy them. There will be some not so good days. That feels a lot different to the person suffering with Parkinson's disease than bad days. It's framing, language is so important. How we say it, the body language we use, what we avoid talking about, what we feel are the important topics. People need to be heard. People with illness need to be heard. Their story, their version of how this is going helps them cope. And I know and have experienced and wonder how adaptable human beings are. They really, you sit in your chair and think, I could never stand it if I had to use a walker. But then maybe with your illness, you need to use a walker to be safe. And suddenly you can. This I can't until you're there, you don't know. Listening is one of the most powerful and safe medicines that I have. I can listen. This is actually a big part of why I went into medicine. I realized people could tell me stuff and I could listen. And listening matters. It helps people get through challenge. Instead of obstacles of illness, we have challenges. How can we get through the challenge? So focus on getting through it.
Well, Dr. Borman, I see you jumped ahead to where I was going in final thoughts. So that just about wraps up pretty much this session. I really want to thank our subject matter expert panel for the phenomenal job and the responses you gave us today. Thank you so much for your time and efforts. With that, we're going to take a quick 15-minute personal break, so use the restroom if you need. But don't go anywhere, because coming up, we've got Dr. Webb Ross with our health update or research update, which I think most people know Dr. Ross knows. I'm really looking forward to this. It's going to be a great session, so Please come back at 12:15.
Ladies and gentlemen, one more time, a nice round of applause for Doctors Michiko Bruno, Jim Spira, Pat Borman. We're going to do some interviews real quickly here in this 15 minutes. Check with the crew. Oh, no, okay, we'll take a break. Copy that, okay. Oh, we want to say mahalo to our sponsors, and we'll do that right now.
See, I would say, when I think of my life story, when it's all said and done, I want people to remember that I was a fighter. Over the course of my career, I did a lot of things for the Air Force, including battle damage repair technician, aircraft electrician, medical service corps officer, and contracting specialist. I finally retired from my civilian job in 2012. Right at the time I got diagnosed with Parkinson's. So it's like, welcome to retirement. You got Parkinson's disease. What I remember, right, Cindy and I went out into the car and just cried for about 5 minutes.
When Dale was initially diagnosed, it affected him. The diagnosis affected him pretty emotional. It actually affected both of us very emotionally. But actually, within just a short period of time, I saw him take something that was frightening and make it positive. And he set up this amazing support group.
The way you react when life hits you with things does define you as a human being. There's some wonderful people out there that I met in the support group, and I feel I need to be strong for everybody for the group to give others hope.
I'm Bill Day, and it was 10 years ago that I was diagnosed with Parkinson's. And I noticed it because when I was walking or jogging, my left hand was not in sync with my regular movements. I was concerned because I was taking more medicine. My disease was progressing at a very rapid rate. And after about 2.5 years, I felt I needed more than just pharmaceutical solution. I did some research on some neurosurgeons, and DBS was very simple. I had 2 implant generators, one on the left side, one on the right side. They were somewhat bulky, and you could see them if you knew I had it. Impulse generators were the last 3 to 5 years, but for me, they were lasting less than 2. And what entered my mind is outpatient surgery every 2 years is too frequent. One of the worst experiences in my life when the battery was at EOS, and it was end of service, and all my symptoms of Parkinson's started returning. So that's when I decided, okay, it's time to explore a change. That led me toward research, and I found Precise. It was pretty easy for me to switch because it was rechargeable. You just put it over your stimulator, and it works. And I do feel like a new man. The children were born, I cannot even hold my grandkids in my arms because of the Parkinson's. He'd ask me to walk around the block, and I can't do that. With the previous system, I felt limited. Sometimes girls would ask me, "Grandpa, will you do this with us?" And I'd say, "Oh, I don't know." I was very reluctant. But with Precise, the new system has given me more time that I can spend with the grandkids, just to see them laughing, smiling. They're really enjoying life, and so am I. And that's a joy that's indescribable.
Aloha, this is Kevin Lockett. I am the clinical specialist for deep brain stimulation for Medtronic here in Hawaii. I'm the only full-time on-island specialist for DBS. We're excited to be one of the sponsors for this great event, and really excited to share our new technology for DBS, which was just FDA approved, including BrainSense technology. Please check it out. The website is medtronicdbs.com, and my contact information is available for you right there. Much aloha.
Aloha Hawaii, I'm Dr. Corey Liao, the CEO and one of the neurologists here at Hawaii Parkinson Disease and Movement Disorder Center.
I'm Catherine Mitchell, the research coordinator at the Parkinson's Research Unit.
On behalf of our team, we want to welcome you to this year's exciting Hawaii Parkinson's Association Symposium. And we also want to thank Jerry Boster and the Hawaii Parkinson's Association for your wonderful support and advocacy for our community.
Here at Hawaii Pacific Neuroscience, we have a lot of exciting Parkinson's research coming this year.
For example, we have a study that really looks at restoring the lysosomal enzyme in our Parkinson's patient. We really hope that some of the studies could help our patients.
To speak with our neurology or research team, please call or text us at 808-261-4476. Aloha!
At first glance, Robert Fitzgerald is a seemingly healthy 55-year-old man. Running is a part of his weekly routine. But just a few years ago, running seemed like an impossible dream. Fitzgerald was diagnosed with Parkinson's disease in 2006. Over the years, his symptoms progressed.
So I'm gonna check your stimulator, see where we are.
Dr. Machiko Bruno is the medical director for the Parkinson's and Movement Disorders Center at the Queens Medical Center. She says Fitzgerald's story isn't uncommon. Dr. Bruno says there is no cure, but there are different types of treatment. One of those is a brain surgery that changed Fitzgerald's life. Fitzgerald underwent the surgery in January. And while he's not cured, Fitzgerald is able to enjoy the little things a whole lot more.
Levodopa is the gold standard for treating Parkinson's disease. On its journey to the brain, there are two enzymatic obstacles that metabolize levodopa, DDC and COMT. The dopa decarboxylase, or DDC enzyme, metabolizes levodopa into peripheral dopamine, which cannot make it past the blood-brain barrier. This, in addition to tolerability issues with peripheral dopamine, is why levodopa is paired with a DDC inhibitor, carbidopa. With carbidopa blocking the DDC enzyme, another enzyme may still pose a threat to levodopa getting past the blood-brain barrier, the ketocholomethyltransferase, or COMT enzyme. The COMT enzyme becomes the predominant peripheral metabolic pathway for levodopa when the DDC enzyme is inhibited. As COMT metabolizes levodopa, the resulting metabolite 3-OMD may compete with levodopa for transport to the brain. As Parkinson's disease progresses, levodopa medication can begin wearing off sooner, resulting in increased off time between doses. While a common treatment approach for off time is to add more levodopa carbidopa, the COMT enzyme remains unopposed, metabolizing the levodopa that patients with Parkinson's disease need. Introducing Ongentis, opicapone capsules, an early levodopa-carbidopa partner for off-time and Parkinson's disease. Ongentis is the first and only once-daily COMT inhibitor. As carbidopa inhibits the DDC enzyme, Ongentis inhibits the COMT enzyme in the periphery. This helps make more levodopa available to reach the brain. Ongentis is a unique molecule in COMT inhibition with prolonged pharmacological effect, allowing for once-daily dosing. Ongentis has maximal COMT inhibition at 84% that was maintained over 65% over a 24-hour dosing interval. Working in the periphery to inhibit the COMT enzyme, Ongentis decreases peak-to-trough variations of levodopa and increases levodopa exposure. Because more levodopa is available to reach the brain, Ongentis is thought to potentiate the effects of levodopa. With more levodopa available to cross the blood-brain barrier, it is thought that more of it may be converted into dopamine in the brain. Once daily Ongentis can help protect levodopa from the COMT enzyme as part of your early levodopa-carbidopa adjustment strategy when off-time occurs in Parkinson's disease. Important information, indication and usage. Ongentis, opicapone capsule.
I've always loved working with wood. I like the smell of woodworking. To do this takes skill. And to do that properly, you need to have the hand coordination. And with Parkinson's, that is all gone. The diagnosis of having Parkinson's disease was at first stunning, and it felt like I was somehow responsible for my condition.
He didn't want to be around people. He would often say, you could just put me on a desert island and leave me alone and I'd be happy. And he didn't want to engage in society.
He wasn't telling as many jokes and he didn't have a lot of energy. I was just really worried about him and I just wanted him to be all right. It was a very emotional time for me.
I like to be in charge and in control of things. And I hated the thought of having to take medication. It feels like I'm stuck. I couldn't control my own moods anymore. I couldn't control my own energy. But medication was starting to have less and less effect, and I had to have higher and higher doses. Suddenly I felt like a new dawn had come about. All the symptoms were gone. I could move around, I could walk, I felt happy, I felt cheerful. Now I was able to do things that I wasn't able to do before. This is part of the new technology that's just amazing. 2 electrodes are inserted into the brain. They can control the number of impulses. You can also control their amplitude. This allows me to vary the amount of stimulation that goes into my brain.
I noticed the difference immediately. I say to people, I've got my husband back. I've got the naughty, cheeky, fun-loving man that I married 21 years ago.
It feels like I have my childhood back, like the father that I didn't have for so many years is finally back. We never fought before the surgery, but once he had the surgery, like, we've been going at each other, we've been having fights, and like, it might not sound like something to be happy about, but I like it. It feels like he's really there.
That's been such a wonderful aspect of the whole thing, because again, I feel I can determine what happens to me.
That's changed him completely. It's like made his life better, for me as well. It's like the Parkinson's isn't really there anymore.
The future you had planned or thought about for yourself can come back into focus again. I didn't know that was what the technology would provide, and that's just been phenomenal.
Welcome back, ladies and gentlemen. 1, 2, 3, 4, 5. Oh, let me go ahead and turn on the speakers on this side. Test 1, 2, 3, 4, 5. Check 1, 2. Test 1, 2. There it is. Thank you, thank you, thank you. Check 1, 2. Let me see. Dr. Ross will be there. We don't need that. We don't need the chairs. Hey, Jerry, this is our final speaker, right?
It is.
Hi, everybody that's on Zoom. Welcome back. You want to move the podium up to the front, center?
Yeah, why don't we do that?
Sure. Okay, cool. Awesome. We're just going to do a little housekeeping here. And we'll come right there. We go. I got that, Jerry. Cool. Hey, come on in over on the seats, gang. We're kind of facing this way just because the camera's right over there, so if you want to come over, if you're okay over there, then that's wonderful. Ladies and gentlemen, please put your hands together one more time. President of the Hawaii Parkinson Association, put your hands together for Jerry Boster.
Thanks much, folks. So we're going to wrap up with, for the last presentation, is something special. It's really, for me, it's kind of funny. Dr. Ross was my neurologist for many years. And a couple of years ago when I was working up the Symposium, I actually was going to take him off the speaking order because I wanted to address something else and we just didn't have enough time to do everything. And then when I met with my board and proposed it to them, thought I was going to get hit because they almost rebelled on me and said, no, you got to put Dr. Ross on because he's just a tremendous speaker. So let me do the official introduction. Here today to give us a research update is Dr. Webster Ross, the Associate Chief of Staff for Research and Development and Staff Neurologist at the Veterans Affairs Pacific Island Healthcare System here in Honolulu. Besides being a research neurologist for the VA, he's a clinical professor of neurology and geriatrics at the University of Hawaii's John A. Burns School of Medicine. Dr. Ross has been involved in clinical trials of symptomatic and potential disease-modifying therapies for Parkinson's disease as a principal investigator with the VA-affiliated PHREI for over 20 years. Ladies and gentlemen, it is my privilege to present my good friend, Dr. Webb Ross.
Thank you for that introduction, and thank you for inviting me. I might be the grand old person here. I've been coming to these, I think, since they started in the mid-1990s, and what has struck me is that every year they just keep getting better and better. And I just want to say congratulations to Jerry and the Hawaii Parkinson Association and all the providers up here and the excellent skits that were done. This has just been another spectacular symposium, and I'm just really proud to be a part of it, and I'm proud to be part of this community. So, big hand, you guys. So, as Jerry said, I'm going to talk a little bit about research, and I'm going to focus on research related to the theme of today, and that's mental health disorders. But then I'm going to take, I'm going to actually expand a little bit beyond that towards the end of my talk, and I'm going to talk about a couple of clinical trials that have been ongoing here in our state and opportunities for clinical trials and participation in clinical trials. Because somebody asked a great question, what can we as a community do now to push our field forward and to try to find a cure and a prevention for this condition? And I think participating in research is one of those ways. So I don't have any disclosures right now. I retired from the VA and about 8 months ago, and I'm very thrilled to be doing research at Pacific Health Research and Education Institute. And as I said, I'll be talking a little bit about research related to mental health disorders, and I'm going to start out actually by talking about a study that I think is really pushing the field forward and contributing not just to mental health disorders, but to finding ways of diagnosing and identifying people at high risk for developing Parkinson's disease, and that is the Parkinson's Progression Markers Initiative Study, or PPMI. And this is a study that actually has been going on for over 10 years now. It's a national study. There are over 33 clinical sites, 11 countries are involved. It's sponsored by the Michael J. Fox Foundation, and the whole goal of this is to enroll people with Parkinson's disease and who do not have Parkinson's disease, and collect data and collect specimens like blood and cerebrospinal fluid, and do brain imaging to try to determine what factors may help us to predict the onset of Parkinson's disease, and what factors may help us predict how quickly the disease might progress, and even what kind of interventions we can do to stop that progression. So I think one of the important things about my mentioning this today is that this study continues to enroll people. And in fact, you can go to the Michael J. Fox website, and you can enroll in this study today. You just go right to in Michael J. Fox Foundation website. That the PPMI study will pop up. You just click on that and go on and enroll. And if you don't have access to the internet, I'm sure that you have a friend or a family member that could help you give you access. This study has been really responsible for so many wonderful papers on blood tests that might in the future predict Parkinson's disease, on cerebrospinal fluid analysis and tests that might help us predict future Parkinson's disease, and neuroimaging. But I'm going to talk about a particular study that has recently been published that talks about the neuropsychiatric symptoms and cognitive abilities in people with Parkinson's disease. And in this is a study that used the PPMI database, and this study compared the frequency of 10 mental health symptoms in about 400 individuals with Parkinson's disease who were participating in the study, and they compared their responses to about 200 people who did not have Parkinson's disease to look at the frequency of each one of these 10 symptoms in Parkinson's compared to people who did not have Parkinson's disease. And then, importantly, they reassessed those same individuals 5 years later to see how the frequency had changed in each one of those groups. So what they found was every single one of those 10 symptoms, and I'll just name them. The mental health symptoms that were measured were major depression. You've heard about all of these today. Anxiety, psychosis or hallucinations, apathy or loss of interest, insomnia, fatigue, which is a really debilitating, and some people would say mental health symptom, sleepiness, rapid eye movement, sleep behavior disorder that you just heard about in the last skit, impulse control disorders, which are mental health disorders that we generally associate with Parkinson's disease medications like the dopamine agonists. And these medications can be associated with impulse control problems such as spending money excessively or eating excessively, and they can lead to a lot of problems in the family, and patients generally don't like to talk about them because they're uncomfortable with them. And so they're symptoms that the providers must bring up when they start people on these medications. And then cognitive disorders or disorders of memory and concentration, including mild cognitive impairment and all the way up to dementia. So all of these symptoms were assessed in this PPMI project. Every single one of those symptoms were more common in people with Parkinson's disease than they were in people without Parkinson's disease. So that right there should tell you something. Everything that's gone on to this point in our symposium today is more common in people in Parkinson's disease, and it is vitally important to understand these symptoms and to seek help for these symptoms and to fold the caregivers and family members in on recognizing these symptoms and getting treatment for them. So. And then when they reevaluated people 5 years later, what they found was that every single one of those symptoms, except for anxiety, became more frequent among people with Parkinson's disease. But when they looked at those same symptoms 5 years later in people without Parkinson's disease, what they found was that the frequency actually went down. So these symptoms continue to become more frequent and to continue to be problem in people with Parkinson's disease. And that's why I just think this symposium has been so valuable. So that kind of gives you an introduction to some of the things that I'm going to be talking about for the rest of the 15 or 20 minutes or so. One thing that hasn't been mentioned a great deal this morning is cognitive impairment and dementia. And when I say cognitive impairment, I mean decline in memory and decline in other areas of cognitive function like language and visual spatial ability. But when I say dementia, I mean that decline is severe enough that it's beginning to interfere with functioning ability. So mild cognitive impairment is a syndrome that we recognize as just having problems with memory or problems finding the right word or difficulty sort of navigating in space, but not so much that it interferes with social or occupational functioning. So about 40% of newly diagnosed people with Parkinson's disease will have some kind of cognitive impairment. And generally speaking, this kind of gets worse over time. So that if you there's been a very good study out of Australia that looked at several hundred people who had newly diagnosed Parkinson's disease, and they evaluated their cognitive function, and then they followed them over time for many years. And what they found was nearly 80% of those individuals developed severe cognitive impairment and dementia by the time they had the disease for greater than 5 years and up to 10 to 15 years. So cognitive impairment is really as much a part of the Parkinson's disease syndrome as all of those motor features. And in fact, it's a characteristic that really interferes with quality of life, and it's one that really deserves to be addressed and to be treated if possible. Dementia, at any given time, if you just took a cross-section of people with Parkinson's disease, probably about 30% of them at any given time will have dementia. So again, this is a really important component of the condition. We have had treatment for dementia in Parkinson's disease for a long time, and these treatments really depend on treatments that have been developed for Alzheimer's disease. And one of the nerve chemicals in the brain is called acetylcholine, and it is very much involved in making new memories in the brain and helping memory cells function efficiently. And we know that in Alzheimer's disease there's a deficiency of acetylcholine, and so medications that we have developed now boost the presence of acetylcholine by preventing the breakdown of it in the brain. And it just so happens that this condition also occurs in Parkinson's disease. So these medications that seem to help memory in Alzheimer's disease also help memory in Parkinson's disease. And specifically, donepezil and rivastigmine have been tested in placebo-controlled randomized trials and have shown to be of some benefit in memory function, and in some cases in benefit with quality of life. So unfortunately, the memory condition continues to decline with time, and these medications become less effective. So really, we're looking for interventions and ways of managing Parkinson's disease that prevent the cognitive decline or at least slow down the progression of the cognitive decline. And there are a lot of different experimental medications that are doing this and a lot of different strategies. And one strategy that is being developed is a way of blocking the abnormal clumping together of a protein called alpha-synuclein. And probably most of you know that alpha-synuclein is a protein that normally occurs in the brain. We don't know what the function of it is, but we do know that in people with Parkinson's disease, there's something that triggers this protein to clump together, and deposit itself in these little tiny lesions in the brain called Lewy bodies, after the neurologist that described them nearly 100 years ago. And there's pretty good evidence that these forms of alpha-synuclein that are clumped together and form these Lewy bodies can be toxic to nerve cells. So there is a whole arm of therapy being developed, immunotherapy and medications that prevent clumping of this protein, that's being developed to try to slow down the progress of Parkinson's disease. And I think that this is really exciting research. It does hinge on this idea that alpha-synuclein clumped together can be toxic, and we don't have direct proof of that yet. But I think that this is a really promising field for actually having something that will modify disease progression or slow disease progression, including a cognitive impairment. So one of these compounds that I think is really exciting, it's called ENT-01. It's still experimental. It is a synthetic version of a protein called squalene that occurs in the gallbladder and liver of dogfish sharks. And it's been shown in the laboratory that this ENT-01 is a very potent inhibitor of clumping together of alpha-synuclein. And the only problem with this ENT-01 is that it does not cross the blood-brain barrier. So the blood-brain barrier is this barrier of cells that keeps toxic substances out of the brain and keeps good things in the brain. And it's a very tight barrier, and it's very important that when we have drugs developed, that these drugs, if they're developed for a nervous system condition, they have to be able to get into the nervous system. Well, this ENT-01 just won't cross the blood-brain barrier. So the researchers who develop it, they said, well, okay, we can't use it for Parkinson's disease, it's the motor symptoms, but let's try it for constipation in people with Parkinson's disease. Because we think that the constipation that's present in nearly everybody with Parkinson's disease is related to deposits of Lewy bodies and alpha-synuclein in the nerve cells of the gut. The gut has a very rich nervous system that regulates peristalsis and transit of food and fecal matter all through the GI tract. So it was thought maybe we could just try this drug and see if it helps with constipation. So they did some phase 1 trials. Phase 1 trials are trials that are looking at safety and tolerability, and this medication was safe and tolerable. And then they launched into a phase 2 trial. This is called the CARMET trial. And what they found was very interesting. It did help constipation in people with Parkinson's disease, but it also had a very mild but still significant signal of helping psychosis that you just heard a lot about in people with Parkinson's disease and dementia or cognitive impairment. So this has actually led to a phase 1 trial of ENT-01 for dementia in people with Parkinson's disease. Now, I told you that it didn't cross the blood-brain barrier, so I personally don't understand how it could help these other conditions, but in fact it did. And so I think in the next 4 or 5 years, we're going to have some exciting news about perhaps a medication that will be effective in preventing or slowing down dementia in Parkinson's disease. There is another class of medications that are being developed that actually slow the progression of Parkinson's disease by boosting the production of energy in the cell. So cells have all kinds of little organelles, we call them, that have different things. We have organelles that get rid of bad substances, and then we have organelles that are called mitochondria that actually generate power in the cell. They generate the fuel, and the fuel that they generate is called ATP. And we know that in Parkinson's disease, for some reason, these mitochondria are inhibited, and they are not as efficient as they used to be in producing energy and ATP. So along comes a medication that has been approved for years for high blood pressure and prostate enlargement in men. The name of the medicine is terazosin. So somehow, and I'm just not familiar with how this was discovered, but somebody got the idea to look at terazosin, its cell cultures in the lab, and what they were able to show was that terazosin in cell cultures boosted mitochondria and improved the production of power, of energy in the cell. And so this led to observational studies that looked at the association of progression of Parkinson's disease with people taking terazosin compared to people who didn't take terazosin. And this is another very important study that came from the PPMI study, sponsored by Michael Fox that I just talked about. And in this trial, the investigators looked at men with Parkinson's disease who took terazosin and compared them to men who had Parkinson's disease but did not take terazosin. And in fact, they were able to show that those men who took terazosin had a slower progression of Parkinson's disease. So this led to a small phase 1 safety and tolerability trial that showed that, that terazosin could be safely given in people with Parkinson's disease. And so now there are future trials being planned for clinical Parkinson's disease as well as dementia with Lewy bodies, which is a form of Parkinsonism that's associated with dementia. So I think that this is another really exciting topic. I'm going to move now to hallucinations. We've had an excellent discussion of hallucinations, visual hallucinations and psychosis and delusions. And Dr. Bruno has already informed you that these can occur in 30 to 40% of people with Parkinson's disease. They're usually visual, but they can be auditory or olfactory or tactile. And as Dr. Spira said, they can range from just simple fleeting hallucinations like a shadow passing to very complex hallucinations of water coming off the ceiling or animals running underneath the bed or people. And they can, people can realize their hallucinations and blink and they'll go away, or sometimes they really become very entrenched in the belief that the hallucinations are real. And there are, our speakers today already alluded to risk factors for some of these hallucinations, and one of those is impaired vision for visual hallucinations, older age, longer duration of disease, and of course, medications, the dopaminergic medications that we use for Parkinson's disease. So I think one of the things that really came out very nicely in the last skit was, when do we intervene for these hallucinations? And the threshold has to be individualized, and it really depends on safety and comfort, not only of the person with Parkinson's disease, but their environment and the people, their caregivers in that environment. So I'm not going to say anything more about when to intervene, but I will say that it really should start, and the speakers alluded to this as well, we usually start by modifying the Parkinson's disease medications. At some point in time, we have done all the kind of modification that we can, and these hallucinations are still a major problem for the person. And so we really then begin to think about antipsychotic medications. And as Dr. Bruno stated a little while ago, these antipsychotic medications can have serious side effects, including making the Parkinson's disease worse. So we definitely don't want to do that. The more recently developed antipsychotic medications, such as quetiapine and pimavanserin, are medications that don't really block or they don't have an effect on dopamine in the brain. They act on other nerve chemicals such as serotonin. So they don't have the Parkinsonian side effects as much as some of these older antipsychotic medications like haloperidol. So we when we really have to, and we really don't like to, but when we're really faced with no other option, and we do use medication, medications such as quetiapine have been shown to be effective in people with Parkinson's disease with hallucinations. And then there's a medication that was released about 4 or 5 years ago called pimavanserin that was actually specifically now has an indication for psychosis in people with Parkinson's disease. We still don't know what the best medication is, however. And so there is now a new study that is a multi-center cooperative study, a clinical trial that's being sponsored by the Department of Veterans Affairs that's looking at the efficacy of quetiapine versus pimavanserin versus placebo in the treatment of intractable psychosis in people with Parkinson's disease. So this trial is just getting started, and I hope that we have some good answers that will lead us to better ways of treating hallucinations in the next 4 or 5 years. So again, another symptom that has been really discussed very eloquently this morning is major depression. And we have effective treatments for major depression. And for me, that starts with talk therapy. And when I have discussions with patients and they endorse mood symptoms like sadness of mood or loss of interest or fatigue or loss of energy, appetite change, and so on, we talk about this, and I'm very quick to refer them to a mental health professional who may initiate some kind of talk therapy, like cognitive behavior therapy, and this has been shown in randomized placebo-controlled trials to be very effective. We have a long list of antidepressant medications. The newer antidepressant medications really work on the neurotransmitter serotonin. Again, this is a chemical that helps make cells involved in mood act more efficiently. It carries the nerve process from one cell to the next. So we have medications that boost that serotonin, and then we have medications that are called tricyclics that have been around for years but are still known to be very effective medications for treating depression, major depression in Parkinson's disease. And one of these tricyclic antidepressants is called nortriptyline. And nortriptyline has been around for over 40 years. When I was a kid in medical school and treating major depression, it was one of the first medications that I became familiar with. Now, nortriptyline has some pesky side effects. It can cause dry mouth and dizziness and sometimes blurred vision. But it is a very potent antidepressant. And so one of the very interesting things about nortriptyline is that somebody made the very astute observation that people with Parkinson's disease taking nortriptyline seem to have a slower progression of their Parkinson's disease. So this actually started people to looking at taking nortriptyline, which has been around for almost 50 years, taking it back to the lab and looking to see what effects it had in cell cultures in cells that are involved in Parkinson's disease. And what they found was that nortriptyline in these cell cultures actually reduced clumping of that alpha-synuclein that actually can be toxic to nerve cells in Parkinson's disease. So, to me, this is just amazing. This idea of repurposing medications that are already on the market and already time-tested and true and found to be safe can be developed for a separate kind of indication and used maybe to slow down the progression of Parkinson's disease. And in fact, there is now an ongoing phase 3 placebo-controlled clinical trial that is actually establishing the effectiveness of nortriptyline versus a serotonergic antidepressant called escitalopram for major depression in PD. But that's only the first part of the trial. The second part of the trial is to examine the potential that nortriptyline might have to slow down the progression of Parkinson's disease, to delay the motor symptoms, the progression of the motor symptoms of Parkinson's disease. And I think this is really exciting. I think in the next 4 or 5 years, we may get the results of this trial, and it'll be really exciting to see how they come out. There is some other really very interesting research in the treatment, excuse me, of depression in Parkinson's disease. And these have to do with hallucinogenic compounds. And of course, when we think of hallucinogenic compounds, we think of LSD and magic mushrooms and all these things that were going on back in the 60s. But actually, there has been a very quiet movement in mental health field over the last decade or so that is starting to look at the effectiveness of these medications for treatment of major depression. And what they found is there have been some amazing studies of treating intractable major depression with psilocybin compound, which is the active ingredient in magic mushrooms or hallucinogenic mushrooms. And then another medication called ketamine, which is an anesthetic that's commonly used in children that has a sedative effect and a potent hallucinogenic effect. So there have been really some very nicely controlled trials that these compounds can be helpful for people with major depression. Now, there is a caveat here. I don't want people to go out now and pick up magic mushrooms and take them if they feel like they're depressed. These are still experimental medications, and they really need to be used under the supervision of somebody who understands them and knows what they're doing and knows what the safety profile of these medications are. And again, I want to emphasize they are all very experimental. So please don't go out and try these things on your own. Talk to your healthcare providers. But there are now a couple of studies that are specifically looking at psilocybin in depression in people with Parkinson's disease. And one of these is an open-label, single-arm, it's a pilot study or a beginning study of oral psilocybin in people with Parkinson's disease who are depressed. And I think we'll be able to have the outcome of this trial in the next 3 to 4 years, but it is ongoing. And then there's another study of ketamine. And as I said, ketamine, it's actually commonly used in children as an anesthetic because it doesn't have effects on breathing, but it does have some hallucinogenic effects and sedative effects. And so ketamine, there's another trial called KET-PD that is comparing ketamine infusions versus placebo infusions or non-active infusions in people with Parkinson's disease who have major depression. So I think it's going to be really interesting to see what happens with these compounds in the near future. I want to say a little bit about, before I just stop, a little bit about COVID-19 infections in people with Parkinson's disease and the effects on some of the mental health symptoms of Parkinson's disease. There have been several studies of COVID-19, just how it presents, how it manifests itself in people with Parkinson's disease. And as you would expect, people who have PD, who have COVID-19, their motor symptoms get worse, and they have more apathy, more loss of interest, more depression, and more cognitive impairment during the course of their illness, but they do get better. They also can have more hallucinations. So, and I think a lot of the hallucinations are just related to being sick, being ill. It's really unclear whether these worsening of symptoms are related to the virus itself, or just being sick, or just being in lockdown all the time. Obviously, isolation does a lot of powerful things to our quality of life. The good news, I think, though, about COVID-19 is that having Parkinson's disease does not seem to increase one's risk of developing COVID-19. And nor does it increase the risk of hospitalization or death, at least in the few studies that have been published in this area. And the other thing is that while there are isolated reports that COVID-19 has been associated with Parkinson's disease after the infection, so far there's really no long-term studies of COVID that show that COVID-19 will lead to Parkinson's disease. And I think this is important because, you know, when we think of Parkinsonism, oftentimes we think of the flu epidemic of 1919, in the early 1900s. And we associate a virus with sometimes wiping out the nerve cells in the substantia nigra that produce dopamine and producing a Parkinsonian syndrome. So far, we really don't have definitive evidence that COVID-19 will cause Parkinson's disease. And lastly, I just want to say that the benefits of vaccination are just as great for people with Parkinson's disease as they are for people who do not have Parkinson's disease. And it does not appear that people with PD have any more side effects than the general population. So all of the recommendations for the vaccine for COVID-19 still also apply to people with PD. One other thing that I kind of like to cover, because this always comes up in questions, and that is the use of marijuana for Parkinson's disease. You can go on YouTube and you can see miraculous cures in certain kinds of symptoms of Parkinson's disease, tremor and dyskinesias on YouTube. And you know, I mean, that may be very true. Michael J. Fox, to their credit, they recently did a survey of about 2,000 people with Parkinson's disease, and they asked a response to this survey. And when they just asked, how many of you use some form of marijuana, either CBD, which is the ingredient that is being used now for anxiety and for certain kinds of seizures and so on, and THC, which is the psychoactive ingredient, the ingredient that makes you high for marijuana, how many use it? And believe it or not, of the respondents, and of course this is not a randomized sample, so the people that participated probably were more likely to use some form of marijuana. But of the 2,000 or so respondents, 70% said that they use some kind of marijuana, either THC or CBD. The problem is that about 15% of those didn't know what form they were using. They all said that it kind of helped their anxiety, it helped them sleep better, it helped them rest. But there was no single Parkinsonian symptom that stuck out as being really benefited from the use of marijuana. And the side effects were very minimal, actually. It was very well tolerated. But sticking with the theme of today's conference, it was associated with impaired thinking and concentration and memory in people who took marijuana. So you have to be very cautious about that. And again, this is something to discuss with your provider, because believe it or not, 30% of this sample, 30% had not discussed using marijuana with their neurologist, with their Parkinson's disease provider. And you know, if there's one takeaway point that from this conference today, is that these medications that we use have all kinds of side effects, and they have all kinds of interactions with other medications. So please discuss it with your doctor. So I'm just going to say 2 words about a couple of trials that went on here in Hawaii, and one of those is the P2B001. This is a combination medication of 2 medications that are already approved for Parkinson's disease, pramipexole and rasagiline. Pramipexole is a dopamine agonist. It's been around for a long time. It's safe, but at higher doses, it's associated with side effects like hallucinations and impulse control disorders. And then rasagiline, it's very safe. It has a very good safety profile, a few side effects, but it only has modest symptomatic benefit. So it was thought by combining these 2 medications in a long-acting, slow-release form that could have to be taken once a day, that you could actually boost the symptomatic benefit and still have a very good safety profile. And so this trial was a multi-center trial and multinational trial. There were 40 centers or so across the world. The company is actually based in Israel. And this was a trial to compare P2B001 with the two components of the medication, rasagiline and pramipexole. And the trial results were just released this past December. We were a site at the Honolulu VA, so some of you may have even participated in the trial. And we were very fortunate to be a site. And what they found was that this medication was as effective as a long-acting form of pramipexole. It was as effective as each one of the individual components, but it had a more favorable safety profile, and it caused less excessive daytime sleepiness. So that medication now will be submitted to the FDA for final approval. And then I just want to mention one other trial that I believe is going on at Hawaii Pacific Neuroscience. This is here in Honolulu, which some of you may be eligible for this trial. And this trial is looking at a medication that actually kind of blocks the activation of another protein called LRRK, or LARC protein. And we know that when LARC is excessively activated, it's excessively activated in people with Parkinson's disease. And we actually, researchers have identified mutations of the gene that codes for the LARC protein that actually produce more LARC than they should, and their risk for developing Parkinson's disease is greater than those people who don't have the mutations. And even among people who don't have the mutations, it seems that people with Parkinson's disease have more highly activated LARC than those that don't have Parkinson's disease. So there is now a medication that's been developed that actually blocks the activation of this medication, and it may slow down the progression of Parkinson's disease. So I just want to encourage you to go online, seek out these trials that may be going on in Honolulu, and if you're eligible, I'd urge you to participate. So that's all my formal comments. I got time. I'm sorry I talked more than I thought I was going to, but I think I have some time for questions. Do I?
Nice round of applause for Dr. Ross, everybody. Dr. Ross, I'm going to put you on this microphone. Test, okay. 1, 2, 2. 2, check, 1, 2. After your speech.
Enough time for about 2 questions, Doc?
Yeah. Two questions, okay. 2 questions.
It may make it easy on you.
Yeah. All right. Well.
Also online, if we just let me know if we get any questions on that side as well.
Yeah. Thank you very much for your attention. I appreciate it. Thank you.
Thanks, sir.
Great. Thanks much, Dr. Ross. Always really informative, and always look forward to those. So I think it's right at, let me see what the clock says, 12:58, and I said that we'd finish at 1 o'clock. So I would say I held to my word. We're about a minute and a half away. So all I have left is some thank yous. First of all, to the audience, thanks for being here. Thanks for taking time out of your day and being brave and coming out in this sort of post-COVID world, but the situation what it is. For the whole group of volunteers, thank you very much. Sponsors, vendors, thanks for your continued support. And a couple of real special ones. Kawi Singh, she's around somewhere. Kawi's over here. She's a facilities manager for St. Francis, and she's the one that really made this possible for me. From my staff, Kai McDermott. Kai's your parking validation lady. Fran Adams, she's a close personal friend. Fran's around somewhere. Fran's over there helping Janice with all the food. Of course, the incomparable Mr. Billy V, the voice. And my last one is the person that really makes this all possible is my wife. If I can get her to come up. Janice, come up here for a minute. Come on. I have a small little gift. I did. For those who don't know what this is a 3-strand 50-inch knee house chalet that I recently acquired. With that, thanks again very much for being here. And we'll call it a day. Let's see if there was a bar here, I'd say the next one's on me, or the first one, but being that this is St. Francis, I don't think we have a bar around here, do we, Mr. Correa? Working on it. Thank you very much again. Have a great day.
Donard, hang on to the broadcast just for a second. I just want to address those that are on the online and watching online. Give me a close-up there, sir. For those of you that are watching online, I want to bring your attention to, there are materials that were on the Hawaii Parkinson Association desk that I think are really vital. If you have questions, contact their resource center. Take, for instance, this is the lineup for today. So there's Parkinson's medical specialists, there's support groups on all islands, on all the major islands, exercise groups. There's online resources, Parkinson's books, complementary therapies, online forums. All this information, you can get it so easily. All you got to do is contact the Resource Center office, Hawaii Parkinson's Association, and you can have all this information really, really quick. They email these out all the time. Mala mopono, aloha a hui ho. VP 808, thank you. Claire.
Oh, no, never mind. Never mind. I was just going to make it now. Volunteers, they're already doing it.
Okay. Hang on for a second.
We're good. We're good.
They're still in broadcast. Donald, how long are you in broadcast? 5 minutes? Copy that. Hey, Jerry, you want me to say something?